company, about 2 years and a half. And what we do mostly is innovation around the pharmaceutical supply chain. So we have created a platform, a mobile app available in iOS and Android. And what it does exactly is it's a platform that allows health facilities to order medicines from it, make payments online, and get goods delivered within 2 hours maximum. So that's much about what we do. And I will be taking less than 10 minutes. And the topic I'll be taking you around is the role of data analytics and the use for evidence-based health supply chain management. Great. So just a small brief. I promise I won't take long, so I need your undivided attention on this. So a small brief. Everybody thinks data is a very difficult topic. I would like to tell you, data is something that is inevitable. We need it for the future. And we have to learn how to harness this data, like other countries, how they have harnessed the data. So data is basically just factual information. It's something that you can use for more analysis, or you can use it as a reference. So how do we apply data in the health supply chain to make it more interesting and more productive? So in our country and other East and Central African countries, these are some of the problems we face. And I'll be speaking mostly on the direction of pharmaceuticals because it's the line that I work in. So one of the issues is out-of-stock products. I'm sure most of you have gone to the local pharmacies. Maybe you're buying some antihypertensive medications, and then you would say, do you have these medicines? The pharmacist would tell you this is out of stock. You'd go to the hospitals nearby, it's the same story. And when you track down this problem, you would find out that people still use paper and pen to create a restock list. So how do you think these people would usually restock their medicines in hospitals and pharmacies? It's based on experience, basically, or feelings. I feel like I should reorder maybe 20 boxes of Panadol, right? But this should be an automated process made by the system. This is how things should go. So due to these inefficiencies, you'd find medicines lacking from hospitals and from pharmacies for a long time. So using data, we can actually solve this. The systems can tell you that instead of restocking maybe 20 boxes, why don't you restock 30 boxes and it will last you for the whole month? So we can actually solve bigger problems in the communities. The other issue is counterfeit medicines. In our market, it's not very tightly controlled. We have counterfeit medicines, and this affect about and they actually lead to 110,000 deaths every year in Africa. It's a big problem. So people actually make medicines in the streets, and they actually sell it at lower prices. And the pharmacists do not feel like it's their problem because they make more margins, right? So these are other problems that can actually be solved if we have a proper supply chain system. And the last one is inconvenient procurement. For those living in Dar es Salaam, you would understand the marketplace for medicines is basically in Kariakoo. That is where our offices are again. So if you live maybe somewhere 20 kilometers away, your facility is there, how often do you have to travel to the marketplace to buy? Will you go there every 3 days, 4 days? It's not practical, right? You might go maybe once in a month. So what if the goods are out of stock in between? What do? You'll just say that they're out of stock. So we need systems that can actually make purchasing easy. In the developed countries, if you have, there are so many platforms, but you can see examples like Amazon. Someone would order the goods and they would be there in no time. But we do not have that benefit. So ordering is difficult. You have to travel, and once you're there, you'll make a long queue. You'll stand there for hours. You'll take quotations from one shop to the other, and everybody here knows our currency. It's a lot of cash. And in streets like Kariakoo, you're not even sure you'll have that cash at the end of the day. They might steal that from you. And then you have to use transport like this, public transport, carry 2-3 boxes. Some of them are bottles, they might break. How do you even carry medicine in that transport? It's difficult, right? And then some of the products are cold chain. You need to store them in special conditions. So all these factors are big problems, and they can be solved with data. If you can tell someone you actually don't need to come here every week, you can just make this order and it will last you for a whole month. That data-driven process is what is lacking from our supply chain. So what are the benefits generally? We can see data-driven pharmaceutical supply chain. This is what we have been talking about. Things like inventory control and helping the customers have a proper cash flow by reducing the expiry of medicines. We have things like research data. We have Muimbili, we have KSMC, and so many other facilities that have postgraduate students, MSc students, people that actually need research data, and it's just difficult for them to get that data. And without data, how do you improve your systems? So systems that are more data-oriented, more data analytical tools can actually help people doing research to have better access to researching tools. I hope I'm making sense. And then we have things like prediction of disease. For example, what we're working with at Mkononi is a system like a heat map, draws a map of Tanzania and tells you that this is the most areas you have been supplying anti-malarials. It can help me to predict that, okay, now there is a high rate of malaria, maybe in Lindi region. These are data that are necessary for predicting and enhancing more strategies to combat diseases. For example, another example is, for example, if we partner with the government, we can have ARVs in our system, and then we can be the distributors of those ARVs, and we can actually provide the trend of how is HIV going this year, how is it going for the next year, and the like. All this data is something that can actually benefit the community in large and the government. And then we have stuff like personalization of inpatient care. You can actually cut the time for doctors. You would understand, you would be in the wards and 70% of your time you're doing paperwork. You're not even actually treating the patient. So what if we reduce that paperwork using AI? What if the system can understand the patient and cut down a lot of unnecessary things in between? So all these are benefits of data. And understanding data analysis, basically, it's grouped into 4. And I'll give you this based on pharmaceutical experience. So we can understand data based on the historical information, how the clients have been purchasing your goods. So you can understand that trend and you can tell them, based on your purchase history in May and June, this is most likely what you're going to purchase. And that falls under forecasting the future. So instead of, for example, they sold 100 bottles in May, 200 in June, I think they're highly likely to spend 300. So these are important figures that you can provide the clients, and you can actually form new strategies. You can actually tell them, why don't you purchase more bottles, lower down your costs, and probably you'll have more people buying from you. So all these are part of data analysis and how you can use it. And for the millennials and people of my age, you would understand these are popular products on the left side. People using Netflix, for example. How do you think Netflix knows that you would like this movie? So maybe based on you watch a lot of action movies, then Netflix is going to recommend an action movie for you, or you like Indian movies or the like. So that is how Netflix works, and that is how it has become popular using data. How do you know Spotify usually predicts the next song that you like based on a database of millions, hundreds of millions of people. And that is how you feel like, how does this app actually know me and know my emotions and stuff like that? And it's all about data controlling. And on the right side is apps, services that are in healthcare. I know most of us don't know about them, but they have been playing a major role in combating COVID. For example, Optum Labs in cancer diagnosis, such as Tempus and the like. So the reason I'm showing this is we can actually do this as well in our country, and we can make different strategies and mitigations. I know we cannot do complex things like genome sequencing and stuff like that, but there are basic things that we lack, basic data that we do not even have. Everything is in raw forms, it's not analyzed, and we can actually utilize this. So, and my last slide would be, how do we envision the future of healthcare? So basically, I don't know, everyone should think about this, but on my side, if you ask me 5 to 10 years from now, what I think is, in pharmaceuticals, nobody will have to travel. It's just going to happen on the cell phone, 2-3 hours maximum, medicines are delivered. And it should be in the same rural and urban settings. And in healthcare, I wish, I do not know, but inpatient care should be very well improved. We need data to improve the whole systems, the automation, reduction of writing notes, reduction of sending lab orders and stuff like that. So that's much about it from my end. And we hope for more partnerships with public and private institutions to make these things happen, because it's very difficult for a team of young people like on our end to handle everything, as you can see. But with the right partnerships, we believe that everything is possible, and we do not have to wait for everyone to just do everything for us. These are easy things like data controlling, and nobody can do it better than the local people themselves. So yeah, thank you.
Thank you very much, Paul. How do you envision the future of healthcare? I won't take any questions now, but please write them down, and after all the presenters have come, we will answer the questions. Next speaker will be speaking on health information exchange in Tanzania, and he will highlight the achievements and challenges. Our next speaker is Teddy, and he is from PAD. Before he speaks, just a brief bio about, oh, my apologies, it's a she. Sorry, Teddy. Teddy is the technical project manager of PAD International. Her main role entails overseeing the design and implementation of digital solutions to improve service delivery in healthcare. She has a PhD in ICT and currently doing her master's in project management at Open University. She's also a consultant with vast experience in project management, business knowledge, design, and implementation of information communication technology related projects. She has been in the marketplace for over 17 years, learning, working, and advising various organizations aiming at digitalizing their business process. She loves life and the people who make it happen. Welcome. Over to you, Teddy.
Good morning, good afternoon, and good evening, depending with where you are. I hope you're able to hear me. And apology accepted. You're not the only one who thinks Teddy is a male. A number of times I receive emails, oh, my boarding passes, and there is a Mr. name. So it is okay. I am a she. Well, I'm going to talk about the Tanzania Health Exchange, the achievements and challenges. And before I do that, I would really love to extend our sincere congratulations to Dr. Sukums and the team for organizing this particular forum. It's one of a kind, and I believe we are heading to a better place as a country and as players in the health sector. If you would allow me, I will go off video then I will continue with my presentation. And thank you for the opportunity to present. I will be as brief as I can because I see we are out of time. So I will have us go through a number of things, but most importantly, I would love to introduce PATH. For those who do not know the organization called PATH and the projects that have taken or overseen the implementation of the Tanzania Health Information Exchange Mediator. So PATH is a global organization that is present to work in accelerating health equity by bringing together public institutions, businesses, social enterprises, and investors. The main core area of operation is to make sure that there is all solutions that are aiming to solve health challenges. So PATH is working globally with government to help governments realize their digital health goals. But we don't only work with digital health, we also work with commodities. Those are areas that PATH works with. But specifically here in Tanzania, PATH is working also in various areas. And I will focus on one particular project that is called Digital Square. Digital Square is a PATH-led initiative that is funded by a consortium of donors who come together to bring funds to help countries solve their health-related issues. So in Tanzania, digital health has been here for a number of years, and the main scope that Digital Square has in Tanzania, I could say for both mainland and Zanzibar is in the slide I have projected. I will not really go to speak about the other activities, but among us, the scopes or the work that we have been doing is to implement the health interoperability layer that is for both Tanzania mainland as well as Zanzibar. So we have done the designing, the implementation, and capacitating the ministry staff to be in a position to manage the enterprise, the interoperability layer. So looking at the health information exchange specifically for Tanzania, we could say the health information exchange is a platform, or health information mediator is a platform that helps systems to communicate, health information systems to communicate, sending one particular information to another based on how the systems are to relate, working. So we came to this particular idea, we in terms of the country, by looking how we can have certain challenges solved. And the main challenges that were there were quite a number of fragmented and siloed systems. We are not new to the health system structure in Tanzania. There are quite a number of systems, those that were in pilot, those that graduated to be live systems, but many of these were operating in silos. They were not communicating in one way or the other to pass information or in helping facilities to offer healthcare with seamless kind of data sharing. But there was also a need to have interoperability because there was inadequate sharing of and exchange of information. Nevertheless, there were fragmentations and uncoordinated business process between one particular system and the other. And so the challenges that really drove the country to think about interoperability were some of these and many more. But there was also an issue of governance and partner coordination. Governance in the sense, who really is overseeing which particular system and who is managing and who is giving a go-ahead. So this system will be used to do data collection for health records, and this system will be used to disseminate information or be used at a particular facility. But also there were a number of partners who were working, who are still here, working for the health sector and come up with different systems. So there was no much coordination. And due to these challenges, thought of having a platform or a layer that would harmonize the systems, have them communicate, and also coordinate these issues of governance and partner coordination. So the guiding documentation that really gave much details and gave a go-ahead are documents that have been owned by the government, designed and owned by the government. For instance, in the mainland, we have used more of content from the Health Sector Strategic Plan 2015 to 2022, as well as National Digital Health Strategy 2013 to 18, and it goes to 1924. And for Zanzibar, we use the Zanzibar Digital Health Strategy Investment Roadmap. These documentations have stipulated what the country is aiming to achieve regarding digital health. And I would encourage us to read, if at all we have not really gone to ever explore them, for the benefit of having the knowledge and also understanding the move and direction of the government regarding digital health. But the why part of interoperability is that we needed to have information that is being shared to speed up flow of information between systems, between entities, between individuals, but also reduce the workload of eliminating duplicates. We would have one particular 2, 3, 4, 5 systems collecting similar information and probably using similar kind of processes to manipulate that system, and the data use would be more or less the same. So there were quite a lot of duplicates because one system would collect health client or patient information and another would collect. And whenever there would be a need to have consolidated report, you would find there is a lot of duplication. So it would be very hard to know which particular facility has taken care of how many clients, or a hospital, how many clients have been registered on a day-to-day basis, how many clients have been given service. So you'd find the duplication because of lacking that seamless kind of information. But we also see the why, because there was a need to have a single point of truth entry where we could have data captured in one particular area or one system, and then the data is being used by multiple systems, but also to enhance decision making. When we have reliable information, then decisions will be made based on the data that is available. So it's have enhanced evidence decision making, but also increased data visibility. Client information across board for people to see, health practitioners to say and know this is a patient, you are taking care of the patient, who you have, their health information, past history, and all records, so to say, based on how many times they've visited the facility and the diseases that they are being addressed or diagnosed with, and things of the sort. So the aim was to improve availability of high quality data, to have planning that is evidence-based, service delivery, but also decision-making that also is well informed, not just to decide and say we're going to purchase, maybe the government says we're going to purchase this kind of health commodities, and what is the basis, without knowing the demand of these particular health commodities, or we are supplying this particular facility with this medicine, but what also is the demand? So the Health Information Exchange has come as a solution to promote evidence-based decision-making. So the evolution of the system, or evolution of the health information integration, I would say, as I've explained before, there were multiple health information systems. We know the ministry has more than 100 information systems, but also these were much in silos. There were no standards. There was a lot of redundance of data, but duplicates and a number of gaps. So this moved to having some national system that was scaled up and were used in different places. For instance, DHS2, ELMIS, HRHIS, and some of these systems were connected. The connection was peer-to-peer, where you would have one system connecting to the other. It was okay for a particular moment to solve a solution, to solve certain challenges. But then there were still gaps that were existing, like architectural gaps, but there was also limitation in governance. So the future that came in, and that's what we see, it will continue. But now with the interoperability, there is an enterprise architectural thinking. The systems have been thought of in a manner that this particular health information mediator that has been built comes as a harmonized, or a mediator is called. And there are quite a number of systems now that have been connected through the mediator and the sharing of information assemblies. But also we've created common standards and guidelines through working with different source and destination system and with the guidance of the government. But now there is also formal governance structure that is foreseeing and overseeing all these kind of initiatives, and that's a digital health steering committee. But also there is also linkage of systems with the government system, the likes of Muungano, and for Zanzibar, like ZAN EMR. So looking at the before and after, I've covered this slide with my previous explanation. Everything that was point-to-point or peer-to-peer integration, we see the future that has taken place already is that we have seamless sharing of data through the Tanzania HIM or Tanzania Health Information Mediator. That is for the mainland, but even for Zanzibar. We have the interoperability layer that has been developed. So systems are sharing information, and the governance part of it is fully in control. They're looking at how the systems can be coordinated and share information. So there are common standards and guidelines that guide developers of the system, both source and destination, but also they guide the way of integrating. The beauty of having a mediator is that each and every system will be designed in the manner that it's being designed, but there is a mediator that really harmonizes the communication. So whoever sends patients, whoever serves patient information, probably name, and one system serves a name as a code and say this is Teddy, Teddy will be identified as 01, and another system says this is Teddy, and Teddy will be identified as C3. So by the time there is a need to share Teddy's information, the mediator will translate or record that information about Teddy and share to the other system in a manner that the system will receive and understand what exactly they have requested. So speaking of achievements, for Tanzania mainland, this is what it's just a snapshot of what we have been able to achieve. I will just briefly speak about this diagram that you see. So to my left, you would see broader than health shared service application. So through the health information mediator, we've been able to integrate different systems. So there are shared digital health services, the likes of HRHIS, that is keeping information about the human resource individuals, but also the health facilities that are being registered and updated. We have the product registry, the client registry, terminology services. But also to my left, we have systems that are keeping information that are broader than health, the likes of identification system like NIDA, RITA, CRVS. These are keeping information about individuals who we have called health practitioners. So there is an integration between, for instance, human resource HRHIS with NIDA. It pulls records of a particular nurse or a particular doctor who has been registered to my right, here we see health business domains, in particular farmers councils or institutions that have been trained. So there is a lot of integration that have taken place. This is just pictorial, but there are use cases that have, by use case, I mean the qualified information that is being taken from one particular, is passing from one system to another. But we also have like facility level system, the likes of Gotomis, of Care. They also connect through him to give information to other systems. So him, or Tanzania Health Information Mediator, is a layer that receives all information, translate it in a language or manner or terminology that will be used or of a benefit to the other system. So the color coding we see here, all these greens that we see, green, these are systems whose use cases have gone live and there is information sharing, but there's some that are still in process of going live, the likes of product registry. We are working to have them go live where information would also go across. So just a little level down, integration and use cases that have been configured. For instance, from the diagram that I just shared, the health facility registry that is connected to a number of systems. So they send new facility registration, and also if there is any facility that has been updated, that information goes across board to let LMIS know, MSD EPICA 10, and for instance, now with MSD EPICA 10 with LMIS as an integration, there is sending of daily stock status and also sending of out of stock notification, information that will be needed both side ELMS and MSD EPICA 10. But there is also integration. For instance, NHIF sends health information for facility claims to HDR, and also sends information about health practitioners to HRHIS. So I've just given a few examples, but then I'll go to Zanzibar in the interest of time. So with Zanzibar, we have also set up the Zanzibar Health Interoperability Layer. This is just a snapshot of the dashboard and the kind of integrations that we have them go live. For instance, now Coconut sends weekly malaria surveillance data to DHIS2. Jamini Apia sends monthly SHB data to DHIS2. And that has really helped to get the visibility of what is happening, but also share information and promote decision-making based on evidence. Looking at the challenges that we see, and these are existing, some systems are not ready for integration. They're not mature yet for integration, and mainly source systems. So if you want to do integration, you find a system that is not well developed, or it has not reached a level that you can say it can be interoperable. But there is also an availability of standard codes that can be used, for instance, terminology, let's say for health commodities, to have particular terminology that if they can go through the KIM, then they will be understandable. And then the data quality in some of the source system has been a big challenge, I think, because there is no particular format for data collection. Each one of the system collects data in a manner that fits or suits them best. So that is a very big challenge when it comes to interoperability. We need to have data that is clean, data that is of quality, that it can be translated and be used for decision making. And lastly, opportunities that we see in the interoperability or information exchange. Using the information exchange or the mediator, it increases the ability to use data, compare data across domains, triangulate and compare data across domains or institutions. So with data use, I'm looking at this, it also helps in point of care. So you could have information for a particular client who can be given good service because whoever is giving them this, whoever is rendering the service of care, they have the historical information and can easily handle them well, but also enhance the collecting of data once and use it multiple times. I think I spoke about it in the beginning, that we could have one particular form or system that is collecting data instead of all the other systems to be data collection tools, then it can be used multiple, but better continuity of care. And also the platform can be used to offer community or referral from community to facility and lower to higher facilities. So there are quite a number of opportunities. I've just mentioned a few, and I think my time is up. Thank you very much. That's it.
Thank you very much, Debbie. Awesome. Again, because of the time, I won't take any questions now, but please write them down. And then we have 2 more presentations, and then we can take the questions after that. Thank you for a great presentation again, Teddy. I would like to invite our next presenter, Walter. Walter will be speaking on digitally transforming disease surveillance and response in Tanzania. I think Walter is joining us online or physically. Welcome, Walter, if you are in the room. Right, so whilst we prepare for Walter to come, then I guess we can take the next presenter who is already seated here and ready. His name is Josta Melkerson, and he will be speaking on the roles of stakeholders in digital health transformation, and then highlight the quadruple helix model. Just a brief about Josta. He's a leading international business developer with over 25 years experience of driving sustainable innovation for governmental business, promotion agencies, business reading, and UNOS. Josta is he's passionate about fostering an innovative and creative business culture and regularly acts as a public inspirational speaker and moderator. He carries extensive experience from facilitating cross-sector partnerships for the 2030 agenda based on the quadruple helix model. He is currently serving as the Global Head of Innovation and Digital Transformation at LM International. So please welcome Josta with a round of applause. So we were just discussing, maybe after your presentation, we take a quick minutes break for tea, and then we come back to it to continue. No, I think it is. Yeah.
It seems like we are because technology is around.
Here. Which one is the printer?
The thing that
Best.
is really that I have revealed is in the walls of
Best.
That's right. So here, 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 back there. So in the United Nations have in different industries. And that was what the 4 5 minutes on the also. I couldn't see that there was something coming up for free. And it's a lot. So, ladies and gentlemen, are you ready for the presentation about videos? So we'll see if I can get into the machine and get this on the presentation mode. There we go. Go stand here. Right. I've lost some. Now I don't see the up and down on this one. Brothers. Page upside down. Okay, those right. Yeah, and then the other one. Okay. Good. I'll be quick about this then. Very few words about the LM International. We are a faith-based organization. We are in a lot of places around the world. And we work with the most vulnerable out in the field where people have the most difficult situations. But we also work with the authorities, we work with the universities, and we work with the embassies, and we work with the industry, and we work with the trade organizations, and we work with the church, and we work with basically everyone who can move things around. So this is absolutely incomprehensible for most people. What we're doing here is have not this rapid structure. We have and then we have advocacy, we have finance in the right part, we have the this is where we do team most of us. We here in Africa we have on we also speak that up. This you were this about the recent Tanzania and we can help about it. Maria is very no, the other as well. And this one is water. Yes. Okay. So, what else? This is completely idiotic. There. So, just some figures here very quickly. If you see this, we have some 300 people in the organization. We have 3 different continents we work on. We have four different offices that we are working with here in this region. But we also have 45 offices in the complete setup in the world. And we have some 25 countries that we work with. And we have made, which is what we do a lot, which has to do with health and energy. We have drilled 5,000 wells in the last 10 years, which is certainly important. And that means that we have a lot of things to do. So if you look at these things, it looks like a complete maniac's brain, but it's actually what we do. So we have a lot of things going on all around the world, all the time, and we work from everything to everything. So we are really in all the sectors, all the levels of authority, all the different networks, And this is what we do as an operational plan. I will not go deeper into that one. This is what we work on. So we work in water, sanitation, and health. That's a big one. The health sector is super big for us, and also the education and inclusive education. The social and economic inclusion. Everybody should be able to have a decent life. Everybody should be able to have a sustainable future. That's what we say. Of course, this is super important for us, the global goals. We say that we work in those 4 sectors that we just saw, but we also building resilient societies. We're also working a lot with gender equality. We're also working a lot with energy so that things can be off-grid. So if you look at our 4 sectors, we are basically touching all of these 17. So that is what we do. And why do we do it? Anybody knows who this is? If you do, raise your hand. I know. It's a newborn girl or a boy in Tanzania that we hope will have a dignified life and a sustainable future. Remember this little one, because that is why LMF exists. But then we come to the real world. And we have looked a little bit about how the different sectors of the world work together. And this is what happens. What is this? Green, you know what this is. Where is green? It has red up. I tell you, what is this? Yeah, these are water pipes. And they're lying parallelly, and that doesn't help at all. So let's organize society in a different way. We put them like that. Ooh, this looks organized. The problem is that they never ever get in contact with each other. And the water flowing in the left one and the water flowing in the middle one never meets. Then what to do? Of course, we have to organize this. Maybe we should force these people and all the sectors to go into collaboration. Maybe we should do this. Does it look good? No, not really. This is a disaster, but that's very often what happens in short-term projects. We are squeezing things, we throw them together, we decide this is what we're going to do, and this is what comes out of it in society. Absolutely useless. And it's also absolutely, go down. Down. It's absolute stupidity. Look at those birds. One of them might be from the business sector, the other one from the health sector, and they're sitting there ticking and picking, and never do they touch each other, never do they get the seeds. And they're completely locking themselves up in this pipeline system. So what we propose to do, and what we have done back at home where I live in Sweden, and we are starting it now together with Doreen in Kenya, is to do this. This is Swedish text, and this just shows the model. Here we have the civil society, we have the academia research, we have the business and export sector, and we have the local authorities. Those authorities, and you can't read the names, but it doesn't matter. They're coming from these sectors, and they have decided to work together to really accomplish something, not being those two stupid birds. And what that comes into later on is that we also have a very good collaboration around Global Goal 17. We have heard it all over these presentations. We have to collaborate, we have to go together, and we have to create something that actually is bigger than our own contribution from each side. And that is what we try to build. So we have the business community, we have the universities as a research, I guess quite of you are coming from that part. We have also the civil society and the NGOs. We are coming from that part, to say that many, many, many others. And then we have the government and the authorities. And they can move things. And we believe that we, LM International, can be a neutral platform for them to meet. We have no own agenda except this little child born. And that is what we're trying to create also here in due time, and we already started where you are doing in Kenya. And that's very important to see because everybody has some sort of contribution. And the thing is, when they collaborate with us, they do the same thing as they always do. The things that they're good at, they bring into this platform. And then the things that they want to have as a reward, maybe help to people that we have seen in some manifestation, that comes out of it. So it's a give and take, but it's more of a give. And it certainly is a win-win situation. Everybody contributes, neutral platform, no ego interests, and we can really do something. So that is what we are doing here. And that is what this is all about. The lecture, if I may call it one of those, is that we have responsibilities. So what can they do? I mean, this is something we do right now. We are not this. We are not this. We are not. We can lose it for now. All the superintendents are like this because there is a partner and they're quickly and this. And we have the we have the cycle, we have areas of the business areas. This is the goal of the banks. And the banks in my world also very neat American development. And this, they are all this. And this network that we have, and two people that we need. And you see a big generation for and that is everyone. They go so much about that to this stage. When you understand keeping the rest of that, you're very good at this book, knowledge, maybe all the professors in the world, and all that students, some of those people really that's story later after listening. Some of them about generation was. Brilliant. And then you come along, we learn to decide what the reward is. Now, they will book that. All these things, all this training, all the English, modern development, all these things about of the university of the we can learn work with development support. This is more the evidence back between we feel not the wrong time, that's why we have this great experience, we have the work, we never routine, we never the confidence, we have the movement of the hospitals, we have other things, very common it's very important because here and in what many places we were through the challenges, we were through the challenges, we were through the elements. We have a lot of interesting ideas to create a collaborative with you. We really because here at the culture is if you go to Marketplace, it's okay different. If you go to here, 20 kilometers to about kilometers out of the other direction is at 14. Then there's a different parts. We are there. Well, how you understand the very different events and the reason. Honestly, and something I think also one of my kind of book kind of shows businesses or big organizations from governments from others then if you go back as a government and even system, we need to read. You have to think about it. You have to sit here with how are you going to do this use together? It's not only and rights for people. To make water to get to something and be done and we have to do anything. in the challenges we have always got those that are very often one of the governments woman take the generations and all these things that is necessary for us to collaborate. So, this little guy, girl or boy, that is why we are here. That is the future. And that is why we have to collaborate and go away from those pipe and actually work in this, what we call quadruple helix model, where governments, business, and universities, and the aid organizations, the NGOs, work very closely together. And that also gives an insight from each and every one, because we talk to different languages. We have the one word can mean something completely different in an NGO as it does in a government or in a bank or in a business. So this is the reason why we're here. And I just want to thank you for your time. And start with that. Please start with that. And start reaching out. Go into the development of things early. Make all the adjustments and mitigations that might go wrong as early as possible. And then all these structural plans that we have seen, all these development models we have seen, all this big data that we also run around becomes useful. The generation brings that. And value is not the same thing as dollar or money. It could be human. It could be value for community. It could be value for exchange. It could be value for a tourist or somebody the community that we value is much bigger than money. So this is what we want to say. Here's my opinion about. Very good. So thank you everyone. And if you have anything you would like to discuss with us, there is program. It is very important to do. If you want to do something, I will be more to know. Yes. Thank you.
Thank you very much, Yosta. And I think Mohas has created a perfect platform for us to connect and then collaborate on future projects. Yes. So we are going to take a short break for our audience online. If you have any questions, kindly put them in the chat. And then we can also take a few of your questions after the break. I'm sure we are all, we can't wait to get out there and stretch our legs and get a cup of tea or coffee. So we would take, because of the time, let's try to be a bit snappy with it. We will take just 20 minutes for the tea break. Thank you and see you in 20 minutes.
Yeah, exactly. Okay.
Yeah, this one is working. It's not this one.
There's a film. So, karibu.
Ndio.
Ndio.
Ndio. Question. Ndio yenyewe.
Kama vipi? Ni pio ya nani?
Imeandikwa madi sample. So kwanza mkupa au nitabeka.
Yes. Amenipa safina. Kwa tuitoe hii tumanitoe.
Alafu ni rahisi kupresent kwa Adobe au kwa PPT?
Hata Adobe sawa. Vyovyote
I
unavyoona.
think nimekea PPT. I'm comfortable with PPT. Haijasoma? Changamoto ni kwamba waliopote. Yaani kuna flash. Ngeuza. Yeah. Admin. Tuchukue PowerPoint. Yes. Tuweza. Tuweke PDF. Lift sisi tuchanganya malezi.
Karibu.
Presentation yangu.
Inaitwa
ya mwingine ni 20 years. Lakini jina lake hapo nimesave as Madly.
Nadi.
Madly 3.
Hadisi. Kuna mwingine.
Yake alipoweka ndio kama kwa presentation yako jina kubwa.
Shuka.
Fanya hawajamute mpaka size yao.
Good. Good. Yes. He doesn't have. Great. Let's welcome Mr. Gay. He's going to be talking about digital transformation in the health sector and then give us a 20 years of experience from the Muhimbili National Hospital.
Just make sure. Next slide, and on the left and right. Okay.
This is it. Next. This is previous.
Okay, sio kulia na kushoto.
As I said. Okay.
Okay. Good morning. Is it still good morning?
No. Yeah. It is.
Yes. Good morning, everyone. My name is Modu Gay. I'm a director of ICT from Muhimbili National Hospital, and I'll be presenting a digital transformation in the health sector. 20 years of experience from Muhimbili National Hospital. I believe everybody here knows Muhimbili, but I'll give you a little bit of a background. Muhimbili National Hospital, also known as MNH, is a century-old national referral hospital. It is on top of the hierarchy when it comes to the healthcare system within the country. So it plays a big strategic role in realizing the healthcare vision of the country. And it aims to provide sustainable, effective, and efficient high-quality tertiary care for local and international patients. As I said, it's the largest referral hospital in the country. We have over 1,500 beds. Outpatient visits per week, we see 9,000 patients, and we have 1,200 admissions every week. So MNH has also pioneered a major health initiatives in the country, such as kidney transplant, cochlear implant, shockwave lithotripsy, and cancer treatment for the children. So before we got where we are today, back in prior 2003, we had few PCs in clinics or in some offices, but actually they are not being used anywhere in those clinics rather than just for administrative purposes. So based on that, there was now a need for a digital transformation because paper-based system being used had become a burden, and the efficacy of MNH processes wasn't there. Drawbacks with paper-based systems that was faced day to day, they became complex due to the size of the hospital. As you can see, when you have 9,000 patients every week and 1,200 admissions, plus staff about 2,700, it becomes chaotic. So the management, realizing all this and the business benefits, decided to implement an end-to-end EMR solution, which will improve overall healthcare delivery and coordination, ensure data security and confidentiality for our clients, which will also add controls to the financial transactions, and also improve patient experience affected by variant staggered service rendering. And above all, we all need to make money. So we wanted to increase also revenue by controlling leakages and reducing the operational costs of the hospital. So it started around 2002, this idea, but it went all the way to 2004 when the actual implementation began. So we implemented an integrated hospital management information system called the JIVA. Its architecture, it's based on a Visual Basic 6. It runs currently on an IBM Power 9 server, which runs on i-series operating systems, version 7.2, and the database is IBM database known as DB2. But from the front end on clients' PCs, we use Windows OS. Now, the implementation for this system, it was planned to be 12 months. But in actual, the scope crept and it went up to 18 months. And I'll tell you why later down the road. It's something that it's a lesson learned, what transpired. But we went in phases. So there were 4 phases to deploy the system. In phase 1, we had those modules like back office, admissions, ADT, billing, patient management, order management, pharmacy, general stores. And then we went to phase 2, we did LIS and RIS, this is for lab and radiology, operating theaters, facilities management, EMR, MIS, and report generation. Then we went to phase 3, which we did mostly financials, HR, payroll, and then other part of MIS reporting. And then finally, the last phase, phase 4, we did laundry, catering and kitchen, equipment, CSSD, doctor consultation, housekeeping, blood bank, and digital medical imaging. So this is the hospital business process framework. As you can see, the source was from the Ministry of Health. You have the core business processes, you have the support business processes, and then you have the back office processes. As we evolve, these items, they keep on growing. So I'll tell you later, because when we started, let's say, this implementation, some things were not around in the systems or in the business processes, but we had to incorporate as they came up. Things like NHIF, GPG, they are not there before, but as they came up, we had to integrate them too. So the progress, as of now, the hospital runs about 27 modules, and all functions are now run through the system. We have an IT infrastructure, which we have over 700 personal computers, along with network switches and all the other things. And then we linked all the buildings using fiber optics because we did not want to compromise on the speed of the application. From that point, we also went through, now we installed wireless network in the wards, so we can expand the services for people who are using laptops. And then, as I said, these 27 modules, they cover all functions like patient registrations to discharge, HR, management, payroll, procurement and supplies, lab, pharmacies, everything is run through the system. But we also went through down the road, this was, I think, in 2016, 2017, we introduced a voice recognition system for our radiology department. This helps them on reporting of the medical imaging diagnosis or tests that have been done, rather than somebody sitting there and type. So they can just talk and the system will just capture the report and put it in the system. So utilization of ICT services in delivery to patients, 95% of the services have been computerized, which has increased accuracy and efficiency within the service provision. We have reduced time of records retrieval because before we had paper-based, and if somebody came and is looking for just a minor thing, you had to go through piles and piles of files just to provide that information. We have also reduced operational costs, patient waiting time. We have interfaced medical equipment for lab, for radiology. So if a test comes in, it has to be booked through the system, being processed with the equipment, and the results will be sent back to the system. It will not allow you to bring in a test which is outside of the system. So that one also kind of closed the loopholes which we were losing revenues from having samples being brought from outside. So as I said, it increased the revenue collection, And we also went on cashless payment before the GPG came in. So when GPG came in, we just integrated with GPG, so our cashiers are no longer collecting cash. So achievement that we did get through this implementation of the system, we were able also to interface with National Health Insurance Fund, which came way after we implemented the system. Also, we did integrate it with the Government E-Payment Gateway, GPG. We did DHIS2, EDIS. EDIS is an Emergency Department Information System, which is being used at the Emergency Department at Muimbili. What we saw, the JIVA system which we had did not have all the processes that could fit with the Emergency Medicine Department. So we got this another system, EDIS, it's known as WellSoft, and we integrated it with the JIVA. So when a patient goes into emergency medicine, they get attended using WellSoft, and the information is being pushed to JIVA. If it happens the patient needs to go to inpatient, then everything continues in JIVA, but if it gets discharged, also from JIVA. So we have that integration. Then we have a LabNet system. This, my friend, my brother Walter knows it much. It's a laboratory network, which is in 23 regional hospitals that was installed with the ministry, but we have integration with it in case a lab sample needs to come from there to come to CPL. We can track it, do the test, and send the results back to them. Also, we do have an ELP, which is an external lab portal. This is basically for private labs that they use our facility for the lab that they need to send samples, so they can just book the samples from where they are. Let's say ARA in Bagala, they book their sample, they put it on a boda, they bring it in, we test it, and the results get sent back electronically through the portal back to the Bagala facility. We also have telemedicine services. I will talk this afterwards, what we do in telemedicine services. But another achievement that we did, we installed a Motic slide scanner, which scans histology slides or samples, and then it magnifies them, and you can share them with other people and have a discussion and come to a conclusion. So I'll talk about that a little bit later. Other achievement we did, seeds, computer literacy. As you can see, about 2,700 employees that we have, 2,137 are now using the system, and we had to train them. Some of them, they could not even touch or move a mouse, but we had to train them from the beginning. And as I said before, we planned this to be done in 12 months, but it went to 18 months. Part of it was that computer literacy, because now the vendor said, this is my plan, I need to implement it in 12 months, but we have users who cannot use computers at all. So now we have to have additional time to train those people to be comfortable in using PCs before now you can train them on the application side. Well, the impacts that we have seen is timely service provision to our clients. Now they don't have to spend much time from registration, fetching of their records, attending the clinics, and up to being discharged, whether from outpatient or inpatient. It has simplified appointment system to our patients, and it has also improved the health supply chain management, like reducing the out of stock for medicine, because before, when you go to a doctor or to a certain pharmacy, we have many pharmacies within the hospital, and a doctor prescribes, let's say, paracetamol, and the pharmacist would say, I don't have that medication here, while the second pharmacy has the medication. So you tell a patient there's no medicines while the medicines are in the next pharmacy, but this guy doesn't know. So by having this system now, they can see medicines across the hospital. And when the doctors are prescribing it, if I want to prescribe Panadol, the system tells me exactly how many tablets of Panadols I have. So if I describe it to the patient, that means it's in stock. If I don't see it, that means it's out of stock. So I have to give the patient a different medication. For the healthcare service providers, it does help them to make a quick and accurate informed decision, because all the results, they have it right there on their screen. They don't have to go through some paperwork or missing papers that were happening before, misplaced files. So everything they can review on the system, the history of the patient, the medication they had prior to that visit, so they can give that treatment accurately and much quicker. Also, availability of electronic data for research is much quicker rather than going through physical files. For the management, we have realized a big impact on this from the revenue standpoint. I can tell you back in 2011, our revenue, collected revenue was about 9 billion, but as of last year, our revenue is about 80 billion. And this is through the system. Without the system, I wouldn't be at these figures now. Operational costs also, we have reduced a lot of operational costs. We were spending papers for the lab about 100 million every month. Okay. And now we don't have that. We're also spending for outpatient files about 500 million, and now we don't have that. So less paper, less operational cost. Evidence-based planning for the management that we can see, we have the trend of the patient, so we can know exactly what to plan, what medications to get, the numbers of it, and things like that. Access to high quality data, also control of inventory, drugs and consumables. This was a big headache. We are losing a lot here. But now from the minute you order the medication to the point it comes in, to the point it gets dispensed to the patient, that particular drug can be traced and we can say who got what from what batch at what cost and who dispensed it. So no more people putting medicines in their pocket. For the policymakers, of course, they get timely reports from us rather than going through the physical records. We did encounter challenges when we were implementing this system, because the nature of the hospital, it's a big organization. So we have all sorts of stakeholders also involved. We have like the neighbors here, you have MOAS, MOI, JKCI, then you have other people from outside. So we had to put all those into consideration. Data migration, we had a lot of data, unstructured, everything had to be put in together for that migration. Interoperability, range of specialty, multiple patient categories, you have private, exempted, and the rest. Workflows and a huge number of users. We have 2,700 employees. Out of those, like 2,000, if they use the system, it's already a headache. And then, as I said before, computer literacy. We had to train them computer class 101, how to log in, how to move a mouse, things like that before you train them on the application. So those were the implementation challenges we did encounter. But way forward, what we are doing now, we have started deploying laptops for the inpatient wards, so we can use the laptops instead of the doctors using just one computer, so they can go next to the patient with the cart and the laptop and do the clocking from there. We have also finishing up right now, installing a fiber optic ring, which connects MNH, MOI, JKCI, and MOAS. This to enable these institutions to share information, research purposes, training, and things like that, because you have people here working and also treating there. You have doctors treating there, also training here, teaching here, and vice versa. Also, we have linked the system with an electronic integrated disease surveillance and response system. This is through the Ministry of Health. What this does is there are specific diseases that the ministry has said, when you receive these conditions, you have to notify us immediately. So what the system does, as soon as a patient is being seen and the doctor says, this is, let's say, malaria, then the system automatically will trigger and send the information to the Ministry of Health that there is malaria case received at Muhimbili National Hospital. They have different levels of notification, some which are critical, which is urgent, like right now, immediately, and some you can report them weekly or monthly basis. So this is to go live as soon as we have a go-ahead from the Ministry of Health, but everything testing and everything UAT has been connected. Lastly, we are planning on doing telesurgery international, where we can have our surgeons here being assisted with surgeons from overseas. As I said before, we have telemedicine applications. This telemedicine we implemented in 2017, which consists of 2 regional hospitals, and which is Morogoro and Lindi, and we have 2 district hospitals, Nachingwea and Nyangao designated district hospital. In Morogoro, we have Morogoro Regional Hospital, we have Kilosa, and we have there's this other district, Felix. Remind me. Mafit's there, that's for Coast Region, but for Morogoro, we have Turiani, thank you. Oh, so you're here, thank you. Yeah, we have Turiani, and then we have, due to the geographical region situation where Mafia is, we had to give Mafia a special, not we, but the ministry said Mafia needs to get a special treatment, so it did receive also the telemedicine facility. So those centers, they report, like the district hospitals in Lindi and Morogoro, they report to the regional, and then the regional, if it cannot handle, they report to Muhimbili. But Mafia had a special treatment, they report directly to Muhimbili. And what they do over there, they have teleradiology, teleconsultation, where they've been given ultrasound machines, CRs, that they can convert analog X-ray films, because they did not have digital X-rays by that time, but now they do have, which is integrated, so there's no longer use of those CR system. So the image gets sent to Muhimbili National Hospital, and then the radiologists at Muhimbili National Hospital, they interpret the image and they send back the results to the district or to the regional hospital. So the patient does not need now to travel to come all the way to Muhimbili just to be taken an X-ray or to be diagnosed, because they don't have radiologists in those remote areas. So those were the centers which they had the telemedicine system, but I'm running out of my time, so I could have talked more about the telemedicine, but let me end up here. Thank you very much.
Thank you very much. Okay. Yeah. Right. Mr. Gay has to leave, so we can take 1 or 2 questions before he takes his leave, and then we have the next presentation. Any questions? Questions, comments, reflections? We have one. I think you have to come forward, so all I on this and also hear you. And Esther.
Doesn't need to speak to the computer, right?
No, this one.
Or this one as well? Okay, so thank you for the presentation. I have a question in relation to the user-friendliness of the digitalization. Did you receive any other resistance besides you said that you needed the training for computer literacy? And if there was any other resistance from the healthcare workers to use the system?
Thank you very much. Actually, yes, we did. First thing is change management. People always say, I used to do this. Now, when you tell them, no, now you don't have to do this, you have to do the other way around, it becomes resistant. But also, some people view as it was too much work for them. They said, I'd rather just write, and I don't want to go to the system, there's too much work. But another big resistance we did receive is where there was money involved. So people did not want to use the system because they had their own ways of getting money from the patients. But now when you force them to use the system, you're closing those loopholes. So those were kind of resistance we did receive, but we addressed them swiftly, and they're no longer there. Yeah, thank you.
It was a nice presentation, but I was feeling that because we have many programs that are going on in the communities, like the mobile homes, care home women, and we have visions like different areas of like home personally, but we want to home. So how can we systems really integrated that was making it with what we found for that I think this local activity, the person cannot actually hope people that we speak about finding maybe the data or you know, find it there in the system because they use the mobile really the community, they want to want to content. So I have a program that I'm going to say so how to really integrate all these really technology or that each was process.
Thank you very much. I have my colleagues here from the ministry. I know Walter is working on this, but as I'm from a hospital, we did raise this concern, and I know the ministry is currently working. They have had a couple of discussions in how to have this harmony, because one thing, most of the hospitals, we use different systems. So we all have to be on the same platform, where such a thing, as you said, if somebody did an appointment from a mobile platform or whatever, and there was no connectivity, on the other hand, somewhere this information could be stored temporarily until the connectivity returns. But also not just that, also sharing of that information. Because right now we also have a challenge. Somebody's being seen in Bugando or somewhere in Kigoma, and when they come to Muimbili, we have no records of them. We have to start afresh unless they come with paperwork. But if we had a single platform where we could share this information, if I get registered in Songea and my doctor sees me, and if I travel and come to Dar es Salaam, I can say, yes, I was in Songea before. They can pull all my historical data and be able to treat me from there rather than starting from scratch. But I'll leave this more with our colleagues from the ministry. They can talk much deeper. But also I've seen there's a question here from Zoom. Oh, Kakanyela, Abari. Yeah, he says, thank you, great presentation. Would you consider MNH as a paperless hospital already, or are you still working towards that goal? We are not 100% paperless. Yes, we are less paper, but I said the majority of the areas have been covered. As right now, I said we are starting deploying tablets and laptops, but we see tablets a little bit problematic, so we are focused on the laptops for the inpatients, because if you go to inpatients right now, we use papers and the system. So we want to get rid of those papers remaining in the inpatient. But for the outpatient services, 100% paperless. So that's it, Kakanyela.
Awesome, thank you very much. I think we can give him another round of applause. I hope you are not tired.
Thank you.
I hope you are not tired. We've just had some chakula, so we'll have one more presentation and then we do a little icebreaker to just energize ourselves and prepare for the next one.
Yeah.
How do you pronounce his name? Okay. So our next presenter is Dr. Muzuri Kwao, and he's also from MUHAS. He will be speaking about AI in the health sector and highlight responsible and explainable AI-based interventions. So that we need to continue. Next so I heard Dr. Muzuri Kwao is taking a short course online. So we'll have, if Walter is ready, we can take his presentation. And Walter is from the Ministry of Health, and he will be speaking about digitally transforming disease surveillance and response in Tanzania.
Thank you, facilitator. My name is Walter, as you can see, from the Ministry of Health and ICT department. So what I'm going to take you through is the implementation of surveillance system, the IDSR, by the way. And this is, we have got like now they're using paper, but mostly almost I can say 90% we are using technology. And which are what kind of technologies? Of course, we are using both, almost three. We are using mobile phones, we are using applications, Android application, and the web-based. So this is like a background that first of all, it was required by HR to use surveillance and to roll out ADSR. By the way, the country started way back 1998. It was fully paper-based, and from 2022, we started to use electronic. So the picture here shows the way the level of communication, the level from where we are getting report from the community facility all the way to district, region, national, and lastly, WHO. As I said before, we started way back 1998, but 1998, it was fully paper. And from 2011 to 2020 to 2012, we started use electronic, and we started with IVR. It was, we had like, of course, it was piloted in coastal region in Tabora. And I remember that day it was those time. I mean, that time it was very hard to use it because of the situation. You cannot stay online for more than 1 minute or 2 minutes, especially in hard to reach areas like in Tabora. So 2012, we decided to shift it to USSD, and the USSD, the good thing about it, it was easy. And by the way, we managed to use it even in places where there's very low network coverage, and it was, you know, like step by step. So we registered their number, the facilities worker numbers to the system, then they started using it right away. And from 2017, we introduced we call it registry, but it's a web-based whereby we wanted district focal persons to register their health workers in the areas. So there was no need of them to, to come to us straight, but they can register their facilities workers and start to use the system right away. Then from 2020 to now, we are using Android web-based, and of course there's API I can show later. So far for the time being, we are using USSD, Android, and web. The overview, of course, the SARA, we collect two types of report, immediate and the week-based report from the health facilities to all levels. When I'm saying to all levels, it means once health facilities report, when they report it, district, focal person, region, and nation, they can see that report in real time. And as I said before, we are using USSD application, web and a web-based web service to submit this report. And by the way, once they submit, it goes direct to the DHIS, which is our data warehouse for the time being. And this USSD is zero rated. We have MOUs with some telcos, and the connection is zero rated, no charges at all. But of course, for the USSD, there are some challenges. One of them is session timeout. Most of telcos USSD, it stays for like 2 minutes. So once 2 minutes is over, it means now user have to dial again. But the good thing, once they dial again, they continue where they ended last time. Another thing, the system of this USSD is rolled out all over the country, 26 regions, and over 700-800 health facilities. Of course, it's mainland. And they submit both report immediately and weekly report. Immediate report, this is outbreak report, and weekly report, of course, there's a disease which they're supposed to be reported weekly, so they're using the system. Now, how do we monitor alerts or thresholds? So once health worker submits the report, first of all, they get confirmation report that a confirmation SMS that your report has been submitted successfully. And if there's outbreak somewhere, a system send SMS and email to a certain group straight, immediately. And this group consists of focal persons from district, region, and national. And that one, the green one, is like is one of the example of the messages. For example, of course, it says a case of anthrax has been reported by Ndulene Hospital in Ngorongoro District Council. Please follow up with reporting officer at. It shows the phone number of the reporting officer. Then it's easy now for making follow up or to respond. The component, of course, as I said before, the system, of course, you've got health facilities. This is where they report, of course, USSD technology. And for USSD technology, it means what we are using aggregator who connected us with telecos. So our system is connected to aggregator, and the aggregator takes us to all telecos, as I said before. And this picture now summarizes what I said. Now I wish I can I go there? I don't know what about the camera, but if you see this black one, this is the health facility of which they are using both USSD up, and some of them are using even web. So what the report uses is the report special number is saying where you see that it's *1520 *05#. Once they are dialed, they are they connect straight to the system, and then the system, of course, navigate and then go away to where it's database. And for some of the hospitals, national hospitals, and specialty, they are selling now, they are already connected. They are already connected by to them again matters. This is really now what they get anything, let's say outbreak for because at least they are saying that to the database via health information mediator. And as I said before, by the way, in NSR, we've got two types of independent surveillance, the event-based surveillance. Event is more humans, which they get from social media, community, call centers, or delivery. They are both, they can connect straight to the database, and we have got regional district focal persons and national focal persons who they can now straight with this data straight to the system. And this is the dashboard of which every focal person, it depends with the level, can see in this area. For example, district, they can see district, region, the same way, all the way to national. And I just want to add this slide for COVID initiatives. During COVID, we had several initiatives. We came up with COVID app, and this one was specifically for suspect, and it is but it is used in the health facility. And we had now, not yet, we have Afya Msafiri. Now this is surveillance is for travelers who are coming inside the country, and we have got change of COVID, of which once you are vaccinated with COVID vaccine, then you can get your certificate here, or you can book through the system. And we have got Prima COVID. This one is specific for travelers who are traveling outside the country. And all of this, once we are getting, suspect or somebody who is positive, we can collect and send it to EADSARA database, so that we can have, single database which have got all suspect or all people who are positive for follow-ups. And of course, after introducing this EADSARA, there was impact, of which now at least all the districts, they managed to complete or to report easily and timely, and of course consistent. And by using USSD technology now, it is easy for places like where there's no internet to receive or to get data immediately. And of course, through this SARA, now it simplified the response once there is outbreak somewhere, or if there's anything that is supposed to be responded quickly. So this one at least help us or help the ministry to respond whatever is needed and quickly. That's all for me. Otherwise, thank you very much, and I'm glad to receive your questions.
Thank you very much. And Dr. Mizurikal is still not ready, so we will move to the next session. So we will have David Karunda, who is from Sussex University, if he is here. Or I guess David is joining us online. Felix? Oh, cool, sorry. David will be speaking about digital futures, the potential of foresight practices in shaping the direction and future of science and education. But before he speaks, I'll just give you a brief about David. He's a Sustainable Development MSc graduate from the University of Sussex. I hope I'm mentioning right. He has previously worked with PAD, Data Use Partnership Program, as Data Use and Capacity Building Program Officer, and the Commonwealth Young Professionals Program as IT Services Program Officer. He's currently consulting for various organizations with assignments ranging from foresight research on the future of digital development up to 2035 to help shape the direction of disruptive, emerging, and convergent technologies in societies globally. He's also worked to facilitate Africa Data Leadership Initiative, a peer learning and engagement network focused on data governance policies and capacity building. And he's also done works around digital development principles, stewardship in supporting governments and organizing bridge international development and digital transformation. Wow. All right, so let's welcome David.
Good afternoon, everyone. I think Doreen has probably provided most of my background, so I'll skip this particular slide, but a little bit of change as well, because I think Felix has a way of always challenging me with topics to present. I had one very challenging one last year, and today I'm presenting on digital futures. How do we democratize our future together? So at the moment, I work with Digital Impact Alliance, which is housed at the UN Foundation. I'm basically just a community manager, and I manage what they call Africa Data Leadership Initiative. So it looks at data governance, looks at issues of protection, privacy, and sharing as well. But also, as Felix might have highlighted yesterday, the digital development principles. So I am among the stewards who are looking at how the continuous bridging of technology and international development is practiced within our societies and governments. And I would just like to ask across the room if we're all familiar with the documents on the screen. A raise of hands for people who might be understanding what this first icon here stands for.
so no one knows. So it's the Agenda 2030 for Sustainable Development, and from it we have what we call universal health coverage for 2030, yeah. But also for the Africans, we have the Agenda 2063, which is the Africa we want by the African Union. But also Zanzibar has a very interesting document. It's called Zanzibar Development Vision for 2050. We have the East African Community Vision for 2050, but also mainland in 1999 had a 25 years development vision for Tanzania. So these are common agendas, and I don't believe we're in that year yet. We are still in 2022, but we see these documents go all the way back to 1990s. And I think it's the ability of really looking at how the future might be, how do we shape the future, and what does that mean? And so I'm just going to speak a little bit of foresight. We do know, okay, for M&E people, we normally have what we call insights and hindsight. So we use data to learn where we're coming from, what are the insights we have at the moment, but also there is foresight, which is more forecasting, predicting. What does the current data, what do the current trends and issues and challenges tell us about possible futures? So when we speak of futures, it's a very imaginary or imaginative process that helps in strategic planning and policies. And it's about having those alternatives based on what we have at the moment. What are possible futures? What are possible scenarios? What is probable and what is the desirable future or pathway that we want to go through? And this also forms the basis of what we call the Sustainable Development Goals, the 17 colors in the middle, the bottom. So it was a vision of the United Nations to look at how the world will be in 2030, looking at development from 17 areas. And I've just put two documents on the sides. One is banking in 2035, says 3 possible futures. And the other one is energy for whom? Scenarios for Eastern Africa. So these are just examples of reports that provide sort of view on how we can have multiple pathways, or we might consider the future in ways that are maybe utopian or even dystopian, and what that means in our strategies and policies. But why foresight? At the moment, when we speak of sustainable development, it's broken down into 3 things: social, environmental, and economic. But at the center of it, UNDP has called for innovation and digital transformation. These are enablers. And I think when we speak of digital transformation, we have to look at it from all angles. Are we bridging the social divide? Are we enhancing communities towards economic production? But also, are we cognizant of the environmental destruction, and how can technologies help us in that? Now, normally we are used to doing SWOT analysis. I've worked with Felix in the digital health strategy in Tanzania and other strategies. It's very common to see SWOT analysis, but is it comprehensive? Or do we leave other aspects? When we do SWOT analysis, do we consider social, economic, environmental, technological aspects? Now, one of the analysis frameworks for foresight is called PESTEL. So P stands for political. What is the government stability? What are the policies in place? E stands for economy. You know, are we promoting economic growth? What sort of policies or financing that might be needed to consider this? When we speak of social, are we bridging the gap, or are we promoting welfare? What are the indicators in population growth, urbanization, and all that? But in technology, as we all know, no country is an island in technology. We depend on technology transfer and sharing. So what are the international influences, for example, in the local industry in technology? There's an issue of environment. Nowadays, we even have climate smart technologies. How are we considering environment for our generation and the future generations? But also not to forget that we have lawyers in the room. So what are the legal aspects? Local, regional, and global aspects of legal systems and policies when we consider our strategies and plans, especially in the digital transformation. And where does this come from? It comes from the fact that we're so used to addressing assessments using risk assessment frameworks. So if you see the table or the box or the figure on the right, there are 2 axes. So there's knowledge and possibilities and knowledge and probabilities. So what are the possible scenarios? What are possible risks? So when we know possibilities and probabilities of something happening, we normally categorize it as risks. But what if we don't know the possibilities? What if we don't know the probabilities? Do we still go with quantitative methods of risk management? Or do we have to open up and broaden out our thinking and participation? So that's where things like ambiguity, ignorance, and uncertainty come. So they widen beyond what we call risks. And just the second slide is all about why do we do that? Why is foresight important? It's about democratizing how we do our strategic plans and policies. How do we ensure inclusion, which is an issue at the moment everywhere in every sector. There's an issue of inclusion, women, children, special groups, and all that. How is this reflected? And so based on the previous table, when we speak of risks, ambiguity, uncertainty, and ignorance, these are some of methods that maybe could be employed. So with risk, we know there's risk assessment. We've done, people do cost benefit analysis quite a lot. You can do statistical methodologies to quantify risk and all that. But when it comes to things like ambiguity, how do we draw that out? How participatory can we be? How do we involve stakeholders, in multi-criteria mapping to see what are the criteria that we could use to sort of draw out what are the ambiguities, what are the fears that we have in our societies. When we speak of ignorance, it's something we completely have no idea. We don't know what's the possibility, what's probability. So it is the unknown that it's yet unknown to us. But do we leave that out or do we factor it in? So all these methods, I won't tire you with all of them, but just an idea of how the processes might be. So the previous page had what we call scenarios for the energy sector in East Africa and the banking futures for 2035. So how do you make your scenario? So you still want escape assessments, but instead of focusing on SWOT and risk assessment, you can have furthermore diagnostic methods that are very inclusive. But also you have to consider what are the impacts at the moment, but also, 10, 20 years time from now, especially we envisage digital societies, how is it going to be? And what are the scenarios maybe in bridging the gap in digital divide, in exacerbating inequalities, unemployment, and all that? How do we factor all those in? And that's where we use the factors such as political, social, economic, and all that. And once you have all those, then maybe you can provide better processes in shaping strategies, in really even building more agile and participatory governance practices, because we know that technological change is very fast and things change every now and then. So what we have seen at the moment is that most governance systems are playing catch up. So how do we build our systems to be agile and participatory? And I think this is something that is currently in the wake, especially within the development sector, after the UN Secretary General called for it in a common agenda report in 2020. And so these are some more of the documents or other reports or works that look at long-term horizon. At the moment, I work with Felix and other colleagues in MUHAS to do a study on the future of digital development in 2035, looking at how the convergence of technology in societies and development will be, and how can we shape that direction. So OECD have got digital transformation and futures of civic space 2030. You've got OECD again doing global scenarios to 2035, exploring the implications for the future of global collaboration in OECD. And we speak of collaboration, there is digital development collaboration and cooperation that we do every day. That's why you have partners and stakeholders from various places. But also at country level, you've got countries like Vietnam who are trying to future-proof their digital economy. So they've done the horizon in 2030 and the horizon in 2045. What is the impact of technology? So they might have listed technologies and how these can be shaped locally and globally to ensure that Vietnam thrives in their digital economy. And when we speak of long-term horizon, the landscape can be very diverse. We have education futures globally, so it's a very interesting report. It really diversifies old practices, new practices. How can we shape? Oh, I had 10 minutes. Sorry, I might need 5 more. So also in the digital space, we're here because of digital health. So Novo Nordisk Foundation, for example, has digital health in 2035. It's a report on the scenarios and possible directions in healthcare and technology, and not to forget Africa, as much as maybe there is little literature around it, but there are documents like this, which is African Futures, the key trends to 2035, and how do we ensure that we are moving in the right direction. And we are currently at an inflection point, I believe. So how do we transform our future? We speak of sustainable development goals. We speak of inclusion, innovation, and all that, and digital transformation. What can we anticipate further down the road with the rise of trends such as sociocracy, which is a bit of a balance and away from democracy and autocracy. So we have communities sort of governance mechanisms, but also globalization and internationalization of education, of healthcare services, trade, and everything. And we are all here because of digital aspects. So digitalization is taking quite a huge acceleration. We've seen it during the COVID-19 pandemic, people embracing digital solutions, digital tools, remote working, new ways of working and mobility and all that, but also not forgetting the rate of urbanization. Dar es Salaam is projected to be a mega city in 2030. How do we factor all those in when we do plans for healthcare services provision and related services? As I spoke earlier, it's also an inflection point in various areas. So the icon at the middle on the top is written 100 days. So it's a vision by CEPI, which is a coalition that was responsible for COVAX and other mechanisms. So now they're looking, if there is a next pandemic, how do we ensure that we move down the number of days from 300 plus days that it took to develop the first COVID-19 vaccine to 100 days, with hoping that they will save more lives. But what does this take? It's not only technology power, it's also about, international and global supply chains, manufacturing. It's a lot of things that go into place. So we are at an inflection point where technology does not stand alone. So it's a nexus. And how do we reflect that in our governance systems and also in our strategies and policies? The UN has got a common agenda looking at how between now and 2030, we can do better in accelerating our progress towards sustainable development goals. But at the same time, the UN again is doing now foresight and alternative futures to now reimagine what will be the future in 2050. What does that speak to our local societies? Are we doing that? Tanzania is coming to an end in the 25 years vision. Are we embracing another vision? The digital health strategies we do have are mostly in 5 years, but what is beyond the horizon of 5 years? Can we future-proof this to ensure that we have a healthy digital society in the future that we are all rushing and embracing as we go ahead? And this is just a sort of a last slide looking at how at the moment we're focusing on fourth industrial revolution. So AI, machine learning, augmented reality and all that. But I think Japan has sort of led the way now, looking at things like society 5.0. How do we move now from industries, especially in the wake of climate change and all that, and the destruction that we've had in the past 5 years, let's say since the release of the Limits to Growth report in 1972, how do we focus more on things that bring the society more cohesive? How do we ensure that we have things like circular economy in practices? So how can technology really bring about these visions into reality? How do we meet sustainable development goals from various paradigms of technology, whether it's legal tech, jobs, civic, agriculture, or transdisciplinary sort of research that we do in digital development and related areas? And just to thank you all, this is the end of the presentation. Thank you so much.
Thank you very much, David. I think I can take 2 questions before we move to the next presentation. And audience online, please feel free to put your questions or reflections in the chat. Do we have any questions for David or Walter? I guess that means everybody really understood what you said and agree with you. Great. Then we have the next presentation. Yes, we can clap for it. This part I really like. Why? Because we have another lady coming up. I have been standing here for a while. So the next session is a presentation from David, Mohinsi, and Annabelle. And they will be talking about student innovations at MUHAS and kind of give us a brief on their experiences and challenges. The only one. Okay. So just a little about Dr. Annabelle. She's a graduate medical doctor of MUHAS who has pioneered digital health using various university platforms. She's been involved with projects related to sexual and reproductive health and rights education in secondary schools in Dar es Salaam. Currently, she's doing an online course related to programming and data analysis. So she will be telling us about student innovations in MUHAS. Okay, good afternoon. As we continue to set up my presentation, maybe I would like to ask anyone who is not from MUHAS, what would they be expecting to hear about? Anyone? Going once? Going twice? Okay, let me start. So I joined MUHAS in 2017, November. So I've been here for 5 years and I'm going to graduate this year. So my presentation is a history of 5 years of MUHAS, but I know that there's some things that started before, but yeah, it's a summary of 5 years. So, okay. The first thing you have to know in the student innovation ecosystem, there are 3 things: their events, their programs, and at the end of the day, their products. So we have 2 types of events. We have the awareness events and microphone events. So the awareness events just basically explain to students about different issues related to artificial intelligence. So because if anyone who has studied MUHAS in undergraduate level knows that artificial intelligence and anything related to digitization is not part of the curriculum. So we had to start awareness events to mobilize students to know that this is the future and this is what they're going to be working on. And it's not just the traditional healthcare, but this is what we are going to currently be working on in the next 10 years. So that is where the Students' Symposium comes in. Then we have microphone events where students already have their innovations, but we need external stakeholders and people to come in and see what students do and give them comments, and students may get potential investors, and that is when we get Win and Learn, and we get the MUHAS Scientific Conference where we have external stakeholders there. Then we also have intensive programs, which are hackathons. The good thing about hackathons is that we not only do it with Muimbili students, but we also do with the College of ICT in UDism. We also do it with external information and communication technologies colleges. That means it's more collaborative. And then we have the products. And so fast forward, I decided to just stratify these our products into 1st generation and 2nd generation. So on this table, I just said from 2019 and 2020 to be 1st generation, 2021 and 2022 to be 2nd generation. So I'll explain this table further, but I've kept dash here in the active products and the latent products because I don't think 1 or 2 years is enough to fully explain if a product is active or if it is latent. But of note is in 2020, we sort of had less events and only 1 hackathon. Explains that we had less outcomes on this year, but these years have been successful, and I'll explain further. So our first generation products. So in this, before the first event relating to artificial intelligence in healthcare was done in 2019, but there were events that were done relating to artificial intelligence in healthcare and innovation, but not by Muimbili University of Health and Allied Sciences. They were done by other stakeholders like Sahara Ventures, like Mawazo Challenge. So they are the ones who really gave these first products. But then other products started from 2019 going onwards. So I'll just be giving a brief explanation of each product very fast because of short time. But I think you know of Dawa Mkononi because Dr. Joseph Paul has come to present about this. But going fast, we have another one called Afetun. So they deliver health information using cartoons, and it's so interesting. You'd always want to know what they explain using cartoons. And so this is their website. They were established in 2017. And we have Farmlinks, which also does procurement of drugs. And we have our, Latin first generation, that these are the products that were established but have not been active for the last 3 years. But this is what they were addressing. So I'll go fast forward to second generation. So this time around, we not only had digital, but also we not only had service products, but also devices that would help in healthcare. So we have Mkanda Salama, which is to help, it is solving the problem of postpartum hemorrhage. And it is user-friendly and non-invasive way of solving the postpartum hemorrhage problem. So we also have an automatic blind stick, and so I wish I would zoom, but this is the one who innovated it, explaining how it works, that even when you have water or you have something on the solid ground, it would alert the person who is using it that do not go there. So we also have an automatic rehabilitation device. And we have other products that have not been active, but they were started. And so let me go mainly to what we have succeeded. So the first thing that we have succeeded to do is to raise awareness. As you can see, students have really been active to create solutions that of the problems that are really existing in their society to help healthcare, but also we have products in the market, which is also a good thing, but also we have collaboration. Not only MUHAS, but also people from the Ministry of Health, but also external stakeholders like COSTECH, and have been working, and they participate and come to hackathons and give inputs and offer mentorship. And we also have digitally enabled research practices in MUHAS. And we are moving from having traditionally to collect data in papers, and it's becoming more acceptable to just directly, digitally conduct research in MUHAS. And so we have our challenges. Okay, I have not explained all products. I've just highlighted few, but one of the biggest challenge that we have is the intellectual property rights. People don't really know how to go about the law of the digital healthcare, that this is mine and you shouldn't use it here and you shouldn't use it there. And also we have the low market value that for example, the Afetun, they create really good cartoons, but at some point you find that the person who wants to buy them wants to pay them less compared to the effort and the time and the quality of what they produce. And So also, well, there's a problem of inadequate financing, which I think globally all startups have a problem with the financing, because most startups by after 5 years, they're no longer existing or they're no longer operating. So also we have implementation gaps that we really don't have mentorship in the digital field, people who have done similar things that can explain to us, so this is how you go about this and this and this, because the digital innovations are relatively new. So, and even the people who have been in this field cannot really tell you if this works or not. So, and we also have duplicates of products or services that you find. So if you go back here, you find that we have more app which wants to address cardiovascular diseases. How the so they want to see what is your activity per day, how much do you run, how much do you walk, and all that. But this is a duplicate, and you can name so many apps that can do the same thing that they do. And also we have Rafiki Insurance. Okay, this is very competitive because we already have a National Health Insurance Fund that is going to cater for all Tanzanians. So how do you expect that Rafiki Insurance will come and compete with NHIF, which has been here for more than 20 years? So, and also retaining human capital. Many of these startups do not go on because the people who work on them day and night get somewhere else where they can do maybe a better job and whatnot. So they don't continue working on the vision that they originally started. And so way forward. This is a busy slide, but everyone fits in this slide, anyone. So here we have our Directorate of Research and Publications and also Directorate of ICT. Okay, let me start here that we want to have an incubation center, a place where more students can get mentorship from external stakeholders. They can have a mentorship on the financing and the policy regulation. They can have mentorship from on intellectual property rights. And at the end of the day, when they have already been incubated and mentored and they have already attained a certain level of growth, that is when they can go to the market. So this is our vision, that our MUHA's Digital Innovation Hub will be somewhere there. And so this was prepared by me and David, and thank you for listening.
Thank you very much, Dr. Annabelle. That was a great presentation, and you are doing an amazing job. I will take just 2 questions for Dr. Annabelle, and then we will have our last presentation. Any questions? Yes, we have one. I'm sorry, but you have to move forward because of the mic.
Yeah, thank you, Annabelle, for the good presentation. My first question I would like to ask, among the application presented, we've got maybe a specific solution dealing with a family planning. I'm coming from JZ. One of the issues we are dealing, I don't know put in English, but we say it's and we have found that most of youth, they do not attend in S facilities, they feel shy or whatever. So we would think if maybe we have a digital solution which could help the young to go to get the family planning services. So if you have that kind of the digital solution, it could be much better for us. They can think out synergies. And the second issue was on the challenges. Sometimes the startup of course, they face this challenge. But I think the best idea on the academia is to find the business, the big business, and then you can pitch up your ideas, and then you can joint venture with them, and therefore you go slow. Otherwise, if you books alone, it's quite a challenge to find a capital and to penetrate the market. As you have mentioned that there is a challenge, for example, the NHIF portal, but a good idea for digitalization. There's people need the service, that is the community, and then there is a supplier, and the digital stands at the middle. So sometimes you can change the mind to see what kind of the problems is facing the community and how you can penetrate the market. Sometimes you can be like the doctors, IT, lawyers, social workers. For example, now in Tanzania, there's the issue of vulnerable children. How are we going to penetrate this market? There is the issue of interfering with the government like NHIFs and NIMS. But there's a lot of problems they need to be addressed. Yeah, that's my contribution.
Okay, thank you for your contribution. And so there is no any innovation that addresses the issue of family planning or sexual and reproductive health and rights among the adolescents. And thank you for the inputs.
Thank you very much, Dr. Annabelle. So we'll have our last presentation, and it's, yes, please, let's have for the Annabelle. Please, do we have Dr. Prosper in Jao? Dr. Prosper. Or representative of NACP. No. Also, I think at this point we need a little icebreaker. We've been sitting for a while. So let's get up and do a little exercise. I think I will need this one more, but there's two bigger. And I have a few instructions for you. And it's very simple. Do what I say, not what I do. So do what I say, what you will hear me say, and not what I do. Is it yes? All right. So have you seen of Mr. Head, who was needed in the hand? Hip hooray. So if you say see with your eyes, with your eyes. So have you seen or no? Sorry. Have you heard of Mr. Head? So you have you heard of Mr. Head, your head? Who was needed? So your knee in the arm, your arms. Hip, your hips. Hooray. So have you heard? So let's go try. Have you heard of Mr. Head, who was needed in the army? Hip, hooray. That's right. Have you heard of Mr. Head, who was needed in the army? Hip, hooray. So it's now go a bit faster. Have you heard of Mr. Head, who was needed? Okay, so we do it and see what's wrong. Okay, so we try again. All right, have you heard of Mr. Head, who was needed in the army? Hip, hooray. Have you heard? Okay. All right, so we have just a few people standing. Have you heard of Mr. Head, who was needed in the army? Hip, hooray. Have you heard? Okay, thank you very much. We start the second session. Safina?
Break. We can do that now. Just 2 minutes of the brain for the next. We're going to be on health, activity, and privacy. And then in fact, on legal protection, the Tanzanian legal protection. I think that's very interesting. Then you need to then quickly talk about it.
How many minutes? You have 10 minutes. The frameworks, yes, I'll try to be a bit. Go a bit fast. Oh, yeah, slides. Yes, they're in Kiswahili, that is my goal, because the law is in Kiswahili. That's what I want to, you understand? Yeah. Slides. I want to use this slide. I'm just going to use the law as it is, so that I don't translate very bad and they will notice. You know, when you put them and they say, where did you get the official translation? Sure. Until they have the version, which is okay.
All right, we are ready to start the next session. So, Madam Gloria is presenting on health, data security, and privacy, and she will start from the legal protection in Tanzania data protection bill. And then before she makes the presentation, just a brief about who she is. Very short. She says very short, I'll be very elaborate. So she's an advocate and is currently working as the country director for LM International here in Tanzania. She's a policy analyst, gender expert, human rights expert, and a researcher with 20 years of experience working with community development and human rights organizations and faith-based organizations in Tanzania. Her areas of technical expertise include capacity building at local and national levels on issues of human rights, leadership, organizational development, gender, extractives, accountability, and rule of law, and also designing research with the aim of finding evidence for advocacy work, legal and policy analysis, preparation, organizing, conducting interfaith dialogue for peaceful coexistence, as well as movement building. She has managed several human rights programs, advocacy, policy analysis, research, and training on diverse issues, including human rights, gender justice, gender parity, and inclusive development. Other areas of constructive engagement have been on child rights, elimination of harmful traditions like FGM and child marriage, access to justice, involving faith leaders in addressing public concerns, and participation in macro policy processes on contemporary issues such as democracy, good governance, and development. I think you all agree with me. She's the best person to speak on this topic. Over to you, Gloria.
Thank you. Good afternoon, everybody. When I sit here from Monday listening to today, as we are going towards the end, we've been talking of data, of information, of health issues, of digitalization, and the security around digital information and digitalization. So to me, that I've been really following, looking at the programs, the apps that people are using. But the major issue as a legal expert is how safe is all that? How do we protect? And the people from health department knows the personal data is very big in the health sector. What is your name? What is your age? Okay? How do you feel? What is your weight? That is what we fill into the health sector as a basic personal information. So Tanzania has a long journey, and we are happy now on 30th November or 30th October is where now we had a personal information act. And for the secondary school students, inaitwa sheria ya ulinzi binafsi wa taarifa za watu. So it is about your personal information. And it is very important, especially when you are children. Your personal information is there, but who is using it? How is those people using? How are the parents trying to protect your information that they give in the different places? That has been the key. Our act, which is now waiting for the president to assent it, for it to be starting to start being used, has 7 sections. The first section is about what is the name of the act. It also explains where is it used. You know, we are Zanzibar and mainland. And the good thing, this act is going to be used both in mainland and in Tanzania. So it's a joint act for mainland and Tanzania, which is very good. Because there are some acts for those who are not Tanzanian that are used only for mainland, and others we use both. But this one is among the acts that are used both in mainland and Zanzibar. So when you look at the first section of the act, it defines different things. And in the first definition, it defines what is personal data. What is personal data? And that is very key. I'm not so sure if I can get, it is in Kiswahili, so I'm not so sure if I get it very one-to-one translation in English, but it really have highlighted what it means when you say this is personal data. And when you read at the section 3, it says personal data includes which is key. What is personal data? So it says personal data includes your name. It includes your tribe, your age, your status, whether you are married or not. It includes your education. It includes your history of health. Historia ya matibabu, that's very correct. Historia ya matibabu. It includes any record of criminal record, if by any means you have. It includes your work, ajira. It includes your personal financial transactions. Miamala ya kifedha ya mtu binafsi. It includes your ID, the number that you use as national ID, your passport. It includes your thumb, alama za vidole, what do you call it? Your thumb print. It includes any other means that you are using to identify you. That is personal data. It also includes where you live, your address. It includes when you say blood group, I was looking for the blood group, whether you're A, B, or C, but also it includes any other name, if you didn't use yours, used in the collection of data that say at that particular name. So those are called personal data. Then we have another definition which says it is personal data. I don't know, I should call it special, or what should it be in English? Taarifa binafsi nyeti. That is the name they use. Taarifa binafsi nyeti. What is personal? Thank you. Personal private information. And this includes the DNA on top of that. The DNA is part of it. It includes any information about your children. It includes any information about criminal liability. It includes information about security actions that have been taken by you, but it also includes biometric information. Anyone, the law says, anyone who is using such, we say, private personal information needs to abide to this law. And I'll show you how it works. So the DNA, according to the Act, it also includes is it sexual information, like a person who has been raped and you do the test at the doctors, how we call it in a good medical, because in Kiswahili they just say issues around matatizo ya kiafya au mahusiano ya kingono. Okay, that has happened from the sexual relationship, from rape cases. You know, there are those information. Sometimes we take children to the hospitals, they are tested. Those are the really private information according to the Act. The Act also have established that whoever collects the information must be registered, has to be accredited by a committee. So the Act has established a committee, and the committee will register whoever is collecting data. So nobody can collect personal information data without being accredited by the commission. So that's the administration. So we have the commission that will lead the process, but we also have a board that will ensure that the commission is protecting the information that is going through, and that anyone who is seeking to collect the personal information is genuine, will do it in a manner that is for human rights, in dignified way, and will be able to ensure that the information is not leaking or is not used against what was really needed and against the person information. You know, very soon we had our census. You remember the questions we've been asked in the census. Imagine we have no this Data Protection Act. You remember, we don't have it yet until it comes into operation. Imagine if a person is going to use the data that was collected in census in a bad way. You know, they have even, you remember what they're asking, Sirio? Do you have phone? How many children do you have? Where do you live? Even the GPS, they take it. So it's like if a person goes to your data, can come to your home, knows what you have in home, knows how to do, you know, it's all there. And if it's not protected, and if a person, how do you call it in technology? Those who hacks, do you call hackers? Imagine if a person hacked that system with all that information which we provided. And we have nothing to protect that information. It was really a huge number of information, and it is really personal. Because it tells them who slept in your house that day. You remember? Yes, who slept at your person in that day. And imagine if you were to say, and the person go cross and see who slept in your home and hack the information. So the committee that has been established has the mandate. The mandate, first of all, as I said, to register all data collectors, the mandate to deal with any complaints on bad use of data. It has the mandate of taking action toward anybody who has used the data. It has the mandate to ensure that awareness creation is done so that everybody knows about this act and know that the protection of the information is very key. I was just asking myself, remember the information we have in the Facebook, the Instagram, we have it in the other social media. And we have, no one is protecting that. And we have nowhere to complain the use of it. Imagine if it is used badly. Watoto wangu wadogo mko, si ndio? Taarifa zile mnaziweka Facebook. Si ndio? Tunaziweka Instagram. Alafu mtu anazichukua anazitumia vibaya. Si ndio? Ndio sheria inasema tunatakiwa tuzilinde. Watoto wangu wa Jangwani mpo? Sasa tunatakiwa kuzilinda. Then it also the committee has to ensure that the research is done. If the data is collected for the research, they have to make follow-up to ensure that that data is really used for research, not for any other purpose. So they have the mandate to ensure. And at the end, you will see that even importation of data outside Tanzania needs to be allowed. Otherwise, we can't import data, personal data from Tanzania to other countries without being allowed according to the act. It is like what we call it personal trafficking. So if you do so, you will be like trafficking the information from Tanzania to the other country. That is illegal. So it's also protecting transportation of the information from outside Tanzania, but also to create linkages with other protecting information agencies across the global, but also to ensure that they help together with the board to ensure that technology is really used, is being kept, and it is safely used in all the research and in all the storage of the information. It has also given a guideline that the information will be stored or will be used for how long. The minister has been given mandate to ensure that we bring in the guideline that once the information is collected by an institution that has been accredited, for how long can they use that information? So it has a time limit. It's not like when you have it, you can use it perpetual. No, 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 no. When you have it, you have the time limit. And unless you need it, you have to get permission from the commission to continue to keep it. But the act also is talking about uchakataji wa taarifa. That will be data analysis. That's a good way, because that is what they said, uchakataji wa taarifa. Either it's data analysis or data processing. Yeah, maybe that I was trying to get the technology, the good terminology from technologists. Data processing. So they say that in data processing and analysis of the data, you must, for example, if you are doing that, you have the certificate to do that, and you have to request. And if you are given, you will do it. If you are not given, they will tell you why they said you cannot do it. Maybe they have searched and see that you have no that capacity or whatever, but you need the certificate to do the data process. You can't not do the same. But also, once you are accredited to do the data process, you are accredited only for 5 years. It's only for 5 years where you can do the data processing. After that, you need to request again if you want to continue to do the data processing. But also, there are some criminal action and some punishments for any person who is going against this act. So anyone who, for whatever reason, will take the information and personal data information against this law will be in prison for 5 years, not less than 5 years, and will have a fine from 1 million to 10 million for using personal data information against what they are supposed to do. But also, they have what they really call health data. And they really put it, this is a health data, which is really personal. And I think maybe they put it because of maybe of the using the research, protecting privacy of the patients with the information. I've seen the government saying now it's easy to see if the patient have started in a clinic, it's easy to connect the information to the national hospital. But how is that information protected through that process? How is it not leaking and say, you know, Gloria is now sick of cancer? Well, I've not said to anybody and I don't want to tell anybody. But remember, this is shifting from the small clinic going through. So I think that is what they say, it's very serious in health cases, that should really be private. You should get the permission from the client to ensure that you get the information. But also they said, whatever information, the personal information that we have, it should be used well. And it should be used for the purpose that was really collected. For example, as I said, for the census, it should be used really for the census purpose. If you are using it to collect for the children maybe going to school, that should be remain for the students and for the education system to ensure that that's the data they want to use. So it should be used for the purpose that it was really collected. Another big issue is that the security. It's a big provision on the security of the personal protection. And they say that the personal protection, the security of personal data, will be, somebody will be appointed as you do the data process and will ensure the security processes. I tell you sometimes when you read in English and in Kiswahili, you get confused. Kwa kuchukua hatua za kiusalama zinazohitajika kwa taarifa za usalama dhidi ya upotevu wa uzembe, utekelezaji, ubadilishaji, upatikanaji au uchakataji wa taarifa binafsi bila idhini. For example, you have put your fingerprint and you know the police are doing what when they do the, what do they call it? If you're a criminal and they want to do the forensic, what do they call forensic tests? They use personal data, isn't it, to know who do this. But during that, they really need to, somebody has to take steps to ensure that at the end it's not mixed by somebody. Then we say this is his, or when you are doing the DNA, if you don't take it very serious and no one is carrying it, you might say, this is Gloria, where is the information part? So they say there must be a process of security when to ensure that when you analyze that really personal data, especially in criminal cases, in rape cases, in DNA tests, that you are real, the security of it is very key. Then we have how do we share the information? Is also something also that has been addressed by the law, that the sharing of the information and the information that you get from the data process has steps. First of all, is it okay to share it in public? You get the permission from the person who has the data. And remember that when we talk of data here, we include even the pictures. For example, we are taking the pictures here. Those are the, you know, my face is my personality. It is my personal information. You don't share it if I don't allow you to share. Because it is my face. And I don't want to, I say, stop. Watoto wangu, si mnakumbuka jinsi niliwauliza kwamba je, tunaweza kutumia picha zenu because it is your personal information. Yeah, it is your personal information. Before I use it, I have to get your permission to use it. So they say you should ask the person that you want to share the information, and you should also have a contract with him or her to get the data shared. So we shouldn't share if we don't have the data. But also, as I said, it's about how do we transport the information outside Tanzania. So the security services will ensure that where the transportation of information is done is in the country where it is also, they have security laws in the personal data protection, and they will just transport it if it is really important for that person to be able to work, to be able to get some medical attention or some of the needed services. Upon that, maybe I'm working in Sweden, for example. I need my data. Maybe I'm sick, maybe I whatever, then I can say, Muimbili, I have maybe one day I had some diagnosis from Muimbili. Then I allow Muimbili to give the data, maybe to a hospital in Sweden, for them to follow up what happened, what kind of medicine I was given for me to treat. So, but they will ensure when it goes, it is also in the safe hand, that it will not land to the Facebook. You see now this Gloria walking around with her group, she's HIV positive. We have proof from the data that we have seen transported it to somewhere. You understand what they say? So they have to ensure even in the country where it is exported, the information is safe and is going to be used for the purpose that has really been asked for. But also, if the information is going to the countries which they have no real personal data information laws the government said they will ensure that they find a real mechanism to protect that data and to ensure that that data is safe and it will be just used for the purpose that was really asked. I think when they do the regulation, they will tell us how they will do that to ensure that whenever they do that in the countries where they don't protect information, how safe that will the act be. So it has also now the rights of the people with the information that you must be told, why are we collecting this data? Are you ready to give us the data? The way they did it into the census, that when they come, they tell you, we are people from the census, we are collecting data for the census for the level, so you need that information. It's the right of the one who's giving the information. But also, it is like, why do you collect it? That's why in the census, you have all this explanation. We collect it because we want it for planning, for development. So you need to get one. But also, when it is done in the the digital form, it is also important to ensure that the ones who are using the digital filing have also understanding of why we are doing that. So this one gives us the rights, it gives the obligations, but it has also established the commission and the board that will be ensuring. We also have the part of the criminalization of acts that are against the human rights and the personal information, but also we have the right to haki ya kupata fidia, right to get payment in case they have damaged or they misused the information. Okay, so if they have used the compensation, thank you. When you are compensated, when your data has been really used against what it is. So it's not like they will find the whatever they find and they imprison on it, but as an individual, you'll be compensated for the damage caused by the mismanagement of your personal information. And it will really depend on how the judge will see the amount of damage that has been caused by your personal information being leaked to the place that you never expect them to get. So it is very important for everyone to read this act, and anyone who reads it or anyone who has a complaint will file a complaint to the committee. The committee will decide on the complaint, will understand, but if you feel that they are not doing very well, I'm not happy with the decision they come up, you can still go to the High Court and fight for your rights. That I gave you the information and my information has been used badly and I'm not happy. And they said when they do the investigation on the criminal liability or for any other, they will really use high level of privacy, but also high level of the human rights standard to ensure that they don't embarrass the people that they are really looking. Because remember, this is a personal information, and you remember that I said they are personal private information. If we say, ulibakwa, you understand how it feels, eh? That's why I say they will do it also under really privacy to ensure also they don't continue to damage, but also to protect the personality of the person. Thank you very much.
Asante sana. I won't take any questions now because Gloria is going to be in the panel discussion and then we will have all the questions during that discussion. But I think it's very good for us to know. It's very good for us to know about this data protection and privacy. Because sometimes our information is out there, people can use it. So I think with this mandate, we are about to get it because we are about to have a lot of complaints and then maybe get compensated for how our information has been used. We'll take the last presentation from Dr. Muzuri Kwao, And then we will have a panel discussion, and then we can throw more questions at the panelists. And I will leave you in the hands of David, who will take over after me and then moderate the panel discussion, David Karunda. So over to you. When Dr. Muzirikau is done with his presentation, David will take over and have a panel discussion with Gloria, Max Mello from Jamil Forums, Dr. Muzirikau again, Joseph Paul from Dawa Mukunoni, and then Eric from GIZ. Over to you, Dr. Muzirikau.
Thank you very much, and apologies for not being able to attend and present this physical. It's due to other duties. But I really like all the speakers who have presented previously. And allow me to present about responsible and explainable AI, especially for healthcare. As mentioned previously by Gloria, that mostly when we are building AI algorithms, we train them with data, but it matters how this data was being obtained and also how these algorithms are being used, because we don't have to rely on the decisions that they're making. She used a very good example on asking someone who is a victim of being raped, and you're asking them directly that Ulibako is an offense question, whether it's true or not, but that's is not a kind way of asking a victim who is trying to cope after such a very bad experience. So basically, with reference to what is artificial intelligence exactly, for us human, we are already doing this using normal intelligence, but when machines adapt capabilities in learning, problem solving, motion, and planning, they also have intelligence. But we should remember they lack that common sense as human we have. For example, for a doctor who is delivering a bad diagnosis results to a patient, they have this kind of human touch on how they're delivering it. So for machines, they don't have. So it's something which we need to consider. And also when someone is diagnosed with a certain disease, that individual have the rights to know why or what are the signs that that doctor to conclude whether that patient is suffering from that particular disease or not. So we have to consider all these kind of things when we are building AI and not focusing on only solutions which will tell someone whether they have cancer or not, whether they have TB or not, but we have to explain to the end user why we made that decision. And that's why explainable AI, which is similar to the way a human analyst can make decision, also explainable AI should explain to us how did they achieve to a certain particular decision. So by talking with reference to that, let's first look at the status of artificial intelligence in Africa and see how far we are from the explainable AI before we start deployment of these AI algorithms, because many of us, we are racing into maybe driven by the mindset of business that we just make an algorithm which can just go to the market and being used. But looking at where we are now and the distance which we are to the truly AI, which will be less vulnerable to the end user. Of 32 countries in Africa that responded to a UNESCO survey in 2020, only 21 countries regarded the development and the use of AI as a priority in their national development plans. So many countries, almost 11 countries, they didn't include AI as the priority. So we should understand this, why they didn't include, what are the reasons behind, and what should be done to be able to address most of the challenges, and what are the challenges available which limits these countries to adapt such technologies for humankind. Mauritius, which was ranked in the 45th place in the government in the AI readiness index, and South Africa was named 59th, Seychelles at 68th, Kenya at 71, and Rwanda at 87. Are Africa's top countries in the 2020 Global Government AI Readiness Index. So many countries in Africa, they are not yet ready for AI solutions. So South Africa is the only country which was listed in the Stanford Global AI Vibrance Tool. So there's a lot of activities happening in South Africa to support the AI implementation. And also the Government AI Readiness Index showed that Sub-Saharan African region is rapidly catching up with the middle income countries, with South Africa, Rwanda, Ghana, and Senegal leading that. It is sad to see Tanzania not catching up with that. So based on, again, on the previous presenter who is a lawyer, we need to move fast in this region, develop these regulatory authorities, protect end users, protect how data is being obtained for us to be able. So we can't just build AI algorithms, data which was just being extracted from the hospital without the patients being concerned first. So in the responsible AI index sub-index of the government AI readiness index, Senegal was ranked 9th in the globe. And the same report also noted recent government progress towards AI readiness in Tunisia and Egypt. So you can see a lot of activities are happening from the northern part of Africa and the southern part of Africa. And us, especially in the East Africa, removing Kenya and Rwanda, they are the one who are very active in that region. And many countries in that region, they don't have AI regulatory frameworks and even AI policies. So it's just individuals playing around, pushing themselves. That's why the infrastructures are not ready yet for AI. So for positive ranking seems to correlate with the leading African economies, such as we all know Kenya, Uganda, Nigeria, and Mauritius and South Africa are the one of the strongest economies on the continent. So they've at least managed to invest heavily on AI-related activities. For example, there are only 2 supercomputers. If you look at the supercomputing map on Africa continent, you will find only South Africa and Morocco having that such kind of facilities. We have one in Tanzania, but it have not been in operation for several years. And I don't know if it is even ready for AI applications. I know it was a supercomputer for heavy mathematical manipulation, but I don't know if it is even suitable for AI readiness. Some local startups serving big financial institutions, we have some here in Tanzania, rely on artificial intelligence as a service. When I say as a service, is they rely on algorithms which have been developed somewhere, and here they just wrap around those algorithms, and we don't know whether those algorithms reflects what is happening on the continent, because we have different patterns, for example, in finance, in health. So if you use an algorithm which was developed from outside the country, it won't perform fairly to all these areas. So there are some factors which are limiting us on doing this. At least at MUHAS, we're already addressing some of them. One of the things is this computing architecture. CPUs, which are traditionally available in our computers, are not intended to manage machine learning algorithms. Even the fastest CPU may not be perfect for decision for preparing complex machine learning models. If you want a model which can really perform good job, you need a supercomputer to train that kind of an algorithm. For preparing and inferencing is when an algorithm has already been trained, and now we are recalling it to make a decision based on the new data that we have. And on your left, you see one of the examples of this graphic processing units, which at least at MUHAS now we have 6 of them, and we're ready to train and infer these new algorithms which we are developing. So based on this supercomputer, why we are talking now about supercomputers? On my previous presentation, I mentioned that AI is not new. They've been here for years, but it have changed due to development of these fast computing technologies. For example, in 1956, this was IBM 7090, which was the fastest computer at that time. And it could do up to 24,000 operations in a second. In those time, AI was still struggling. Then in 2007, as mentioned in my previous presentation, I think 2 days ago, we mentioned that Google deployed the first AI in 2007 in the iPhone. And the iPhone had a CPU which could perform up to 200,000 operations in a second. So you can see it was during this period when we started seeing AI being developed, deployed on edge devices like mobile phones. And now we have Siri, which is also based on iPhone. So I'm showing you this to show the importance of fast computing to be able to really extract this powerful nature and the advantage of AI. And then now we have AMD processor, which can do up to 8.429 trillion operations in a second. So you can see how powerful and computing resources AI needs. And this is one of the things which really limits us to develop these cutting edge technologies. Another challenge is the open data. It is very difficult to see open data here in Africa. Even in our university, you'll find individuals with access to data, and they don't want to put their data out there. So most of the AI developers here in Africa, they rely on public available data sets, which most of them have been collected from the global north, which doesn't have the same patterns as what is happening here on the continent. And most of the data which we obtain here, since we are not yet ready adopting this technology, most of the data set we develop here, they are not accurate. You find someone, if we do data collection, there are some people who can just cook their data. And when you train the AI algorithm with this cooked data, the algorithm will perform the same way the data is, garbage in, garbage out. Another thing is capabilities, capacity building in AI. We have very few universities in Africa which offers AI-related courses. So there's human and institutional capacity. We need to review our curriculums to be able to include these areas. We have to develop hackathon workshops, short trainings, and the public lectures to make sure, like this one we're doing, to make sure now AI is being understood by both practitioners and also regulatory authorities. Then on the legal and the ethical issues, at least in Europe, they have GDPR, which protects private data. But do we have one in Tanzania? At least something happened like 2-3 months ago. We are trying to do the same, but this puts into question on how this data set is being obtained from the end from these individuals and how it is being used. For example, there's been a trend in the use of smartwatches. Many people who are going marathon, they want to use smartwatches to monitor their physical condition. But just a few weeks ago, Apple announced that they're going to use data extracted from these Apple watches, which are smartwatches, to provide health insurance. We didn't know when we were buying these devices earlier, but now they're going to use that data set for our health insurance. So do we protect the end users? Does Apple follow this? I don't know. I don't want to comment on that, but it's something which we need to take into consideration. But at least in developed countries, for example, in European unions, they have a fine that is higher than the historic penalties of up to 4% of the global turnover of the companies if they misuse the data sets which they are collecting. I remember when I was still doing my PhD, we received emails from different companies which were hosting our data to ask individuals if they are happy for those companies to keep their data, and if you don't want, the company was going to delete that data. But look here in Africa, many, especially here in Tanzania, we are doing mobile money transactions. So these companies, they know how much we have sent to which person at what time. They can analyze that data. They can know our financial position. Do we know what they're doing with those data? Are we protected when they have those data? In other countries, they're actually using this financial related data to provide credit scoring. Try to imagine you go to a bank without having a bank account, but the mobile provider that you are using, they can use your previous financial transactions to decide whether you deserve a certain loan or not. And the reason why we need explainable and responsible AI to protect the humankind is most of the time when you go online, you see how amazing, how good AI is, how powerful it is. But there are some failed AI projects, and many people who have been doing this, they've been hiding this kind of information to stop the public from being careful with the technology. This is Microsoft Tay. It was developed by Microsoft as a chatbot. When it was deployed, I think it was 6 years ago, when it was deployed, it developed and started using abusive languages against the users. So this is from Microsoft themselves, one of the biggest and leading companies in technologies. So if Microsoft can make such a mistake, what about an individual who's living in Buguruni with limited knowledge and understanding of AI, developing an algorithm which can be used in a hospital? So at least in the US with Microsoft, since there are strong regulations around these things, it was stopped. But here, when are we going to stop it? When are we going to realize it is making some mistakes? This is an Amazon recruiting tool. It was developed by Amazon to go through applicants. But later on, applicants were applying for jobs. But later on, it was found out that it was biased towards men and rejecting many female applicants. But at least since they have strong regulations around AI, the algorithm was stopped. This happened in Caledonian. For those who likes football, sometimes we get statistics from the football match we are watching that where the ball was much concentrated, whether it was in the middle or in other sides of the goal. It is doing so by tracking the movement of the football. But later on, when they tried to analyze the algorithm, how it was performing, they found out instead of tracking the ball, it was tracking the referee's bald head. And this is Uber self-driving car with a fatal accident. And this is when we have facial recognition. Many users of mobile phones are now using facial recognition. What if we have a 3D print of your face and you can still cheat it, right? And the list goes on and on and on. So these are just some of the failed AI projects. But if we don't follow responsible and explainable AI, we are going to see more of these in our local settings. Try to imagine you go to a medical hospital and the AI algorithm is there doing screening of maybe malaria, and they tell you are negative. Then you go home, relax. Maybe instead of malaria, they say you have typhoid, taking typhoid medications. So that is going to affect you. So when are these mistakes happening? Some can happen during the learning phase. The same way, I will refer to my previous presentation 2 days ago. If a baby is growing up in very abusive, violent environment, there's high chance that baby is going to also be violent, just because that's what that baby has been exposed to. The same happens to AI. If you expose your AI to a very poor quality data set, it is going to learn what you have exposed it with. So that's one of the areas which these failed mistakes can happen. Also, the mistakes can happen during performance phase when we are measuring. Try to assume your daughter goes to school, studying, and at the end of the, maybe studying about mathematics, but at the end of the examination, they are being tested on physics. So there was no learning there, right? The same thing happened when we are training these AI models, we are testing their performance. So if you use a wrong performance metrics, you won't understand if your algorithm learned and generalized on the data set. So it's not always we're using accuracy. It's not always we're using F1 score. It's not always we're using true positive, true negative. Depends on the particular problem. So if you use different wrong performance metrics, even the algorithm is going to give you false results. So I mentioned earlier about at least there's a bill which was issued in on August 31st, which is trying to protect private information and how this data is being used. I mentioned earlier about these big tech companies which are collecting data set from our daily transaction, phone calls, text message, and we don't know what they're doing with that. Can someone have that legal power to go to the court and ask these companies to delete all the information? At least now, Google in the US, you can request Google not to remember anything. Try to imagine you have a previous bad history, which you don't want people to keep on knowing it. If you go on Google, you search, you still find it. So now people have the right to go to the court and ask Google to delete any previous history, which they don't want it to keep being available on Google. So what is responsible AI? I've been mentioning about responsible and explainable AI. Basically, there are 4 principles of responsible AI. To underscore fairness, I mentioned about Microsoft AI, I mentioned about Amazon recruiting tool, which was more biased towards men applicants than women. Do we train algorithm to be fair? The same way we want a human to be. Try to imagine when someone is biased towards maybe religion or tribe here in Tanzania when you're recruiting. It's something which we don't want to face, right? But this individual didn't just wake up in the morning and decide to be biased towards a certain tribe or towards a religious group. It depends on where he grew, the kind of things he was exposed, the experiences throughout his life. It's when he will develop that kind of habit. The same thing happens in AI. As the AI try to mimic the working principles of human being, even human can adapt the same. So we need to see algorithms which will underscore fairness. Are these algorithms transparent and explainable? Yes, in recent days, they've been possible. Try to imagine you go to a bank to apply for a loan and they tell you, no, you don't deserve this much, but you deserve to know why you don't deserve that. Try to imagine you're going to board a plane and someone will tell you, no, you can't board this plane because there's a terrorist reports about you. You need to know when was that report, what's it all about, and someone should explain to you. Privacy and security. Gloria already mentioned this. How do these companies use our information? Can it keep our privacy? We need to make sure this AI algorithm respect this human-centeredness. Even when you are making a powerful AI algorithm, we should focus on human to cause less harm or maybe even to avoid it at all. So those are some of the elements of responsive AI, and one of them includes explainable AI, where the algorithm can explain. With reference to the explainable AI is artificial intelligence in which the result of the solution can be understood by human when the algorithm explains itself. A medical doctor who is doing screening of TB don't need to know the mathematics and the neurons behind artificial intelligence, but at least can deserve to know if an algorithm is saying someone is having TB or not. Looking on a digital chest X-ray, at least they can see where are suspicious areas on the image, and the doctor can confirm it. Take an example of one of the failed AI, which was caught by using explainable AI. This individual had a neural network, and he trained it by using image of a train, with the purpose of being able to identify a train. But later on, when they use explainable AI, the algorithm was performing well. But later on, by using explainable AI, they found out the algorithm was focusing on the railway tracks, not on the rail itself. So if this kind of algorithm is going to be installed on a self-driving car and trying to cross on a railway crossing, the car will stop by looking at the railway cross, thinking it's a train coming, and it will stop. And those railway tracks are going to be there forever, so the car will stay there forever. But at least thanks to the explainable AI, they were able to see that the algorithm was not focusing on the train. Instead, it was focusing on the railway tracks. On the other hand, this is another algorithm which was trained to detect TB on chest X-ray. And using explainable AI, they found out that the algorithm was actually focusing on the areas which a doctor was also focusing and using it for decision making. So why do we need explainable AI? I've explained a bit earlier. In diagnosing what went wrong when a robot or autonomous car is involved in an accident, would also benefit from explainable AI. If an AI algorithm makes a mistake, who do we sue? The person who developed the algorithm or the algorithm itself? It's still a discussion which is in the AI community. Also being able to query a machine about why it took action in which led to a particular incident, for example, during loan application. Thank you and welcome for questions. So generally, I can just generalize by saying that yes, AI is here, it's amazing, but if it is not regulated, if it is not developed with the standards which we want, we are going to see a lot of mistakes performed by AI algorithms in our streets. Thank you again.
Hello. Thank you, Dio, for another interesting presentation on AI. Are there any questions? And here's for our last session before lunch. I'd like to call our panelists for the session on health data protection and privacy in Tanzania, challenges and prospects. We have Gloria Mafole, Maxence Melo. I think some of the participants might not be able to join us. So we've had very interesting conversations around data protection and privacy from Ms. Gloria Mafole, but also from Dr. Mzuri Kwao. And as a wrap up to our forum, our last session is it's a panel discussion really on what are the challenges and prospects of ensuring protection and privacy of health data and information in Tanzania. And for those who were maybe here for the training on Tuesday, we sort of covered some enablers and safeguards, looking at institutions, regulations, capacities, but also on literacy and architecture in enforcing privacy, in enabling data sharing, but also overall in strengthening governance of data. And we're going to focus on some of those pillars today, looking at how laws and regulations, which Gloria has spoken very widely, but also looking at how our institutions are aligned or maybe need to be aligned, looking at capacity at human level, institutional level, as well, and last, looking at maybe sort of informed populace, citizens, because I think in the end, all these regulations are protecting citizens and consumer rights, especially in the digital era. Now, I would like to pose the first question. Okay, so we have 3 panelists, 2 in person and 1 virtually. So the first question is really looking at laws and regulations. Most of data protection and privacy is hinged on human rights. And I think we have Human Rights Convention. As much as maybe we are yet to have a digital rights convention, but looking at it from ethics and moral hazards lenses, in protection and privacy and overall in governance, how can we shape our laws and regulations and practices to really amplify the societal values, individual values, and benefits from use of data to citizens? Picking back on, especially now what Mzuri Kwao has just mentioned, how Apple is looking at commodifying data for providing health insurance. We both know in such practices, it might work against citizens in most cases. If I have your data, I might be biased in sort of what quotation I might give you in health insurance. So how can we really shape our laws and regulations in ensuring that despite the moral hazards and everything, we really look at ethics and delivering value to citizens? I would like to welcome our panelists here in person first, and then Dr. Mzuri Kwao. Okay.
Actually, I'm very grateful when I hear the presentation from Dr. Mzuri Kwao, because some of them as a legal person, I didn't know about it, but it was really inspiring seeing that, okay, now we really need a regulation because things happen. You know, sometimes we think maybe it's not happening, but seeing the examples then tells us things are happening and we need protection of the citizen. And to ensure that, as we said, we have to learn, but we also have to have very ethical individuals, especially working in the setups that for example, what the legal framework has established a committee. That committee and the board should be really ethical to make follow-up, to ensure that whatever is collected is really useful, but whatever technologies are well advanced. So first of all, to me, we need to bring the ethical individuals, but also we need to bring in the commission individuals with knowledge, because sometimes when you read the law, they say the chairperson of the committee should be an engineer, should be a person with background in information and technology, can be an individual from a law background, should be an individual from economic background. So there are some fields that have been set up by the law, but we need really individuals who really understand the cause, especially to ensure that you know about the artificial intelligence, how they can be done, how to ensure that it is monitored. So to me, it's like, first of all, we need to have capability of individuals. We need to build the capacities also as we go towards the regulations. So we have now the regulation at hand, I mean, the legal framework that we are working, at least we have advanced. But now, how do we make the legal framework work? And for sure, that has been a big challenge. We have many very nice laws. The implementation of the law is always the biggest challenge. And giving this field as a new field in the technology, we really need people with technological background, but also with technological follow-up, because they need to follow up advancement of the technology to understand the mechanism that they are used, for them to be able to advise, but also to be able to protect the citizen from the bad use of the data. So that is what I can say from the other side.
Okay. Any?
Thank you very much, and congratulations to Dr. Sukums and the organization committee to bring this on the agenda. I think this is really very important, and I really enjoyed the presentations of Gloria and Deogratius hitting the right points. I think this is really important, and I was there seeing what we can do next, but that will be another time to discuss. I think on the African continent, this is very important. So as you mentioned, Deogratius, so we have the European regulations which steer all European countries, and that's a protection itself. And I guess the African Union would be having such a regulation when it comes to artificial intelligence and medical devices, because we have the MDR device made for medical devices, what you can bring on market, on the European market. So it would be really good to see the same thing through African Union, what you can bring on the African market, right? And then we go to the artificial intelligence. Of course, those two go hand in hand, because you may have medical devices where you have also artificial intelligence also together with certain sensors. In many rooms, you'll be sitting like in this room, you'll be having sensors, right? Collecting your data, lots of data. And that data, of course, there is algorithms, and they will be calculating different things. And as I mentioned yesterday, so data is going to be the biggest commodity for business, right? And the biggest companies have understood that. So it's really good to hear that from Gloria that Tanzania is taking the step. And of course, it would be really good to see how you handle artificial intelligence. Artificial intelligence, it has its challenges. Deogratius, I think you tried to show this, that we need also capacity building at all levels. What we see, politicians need to understand this, because if politicians do not understand this, it's very difficult to work on the rules and regulations. And then from there is implementation. Then you go into professionals and community stakeholders. For the university, this is important. How do you create capacity building, training courses that will help students when they go out there to understand these things? And that is possible. We have done in public health. So public health actually created something called public health law. I guess we'll be having something on digital health technology law. That is more complicated, as it has been shown here. But I think the first step is to highlight these challenges and also see what others are doing and what can be done here. The next point, of course, is not only the algorithm itself, but what data is being put there and how it can do harm. And this goes back to the Medical Act, which I guess Tanzania has also. How do you relate to that? Because one of the main points is not to do any harm to any patient or any citizen. And also the openness to know what is there and explain. So this has happened in certain countries. The US through FDA has a database where you see all eye solutions that are on pipeline to get to the market. And that is also helpful to see which are on pipeline to get to the market. Denmark, Martin is here. Denmark has also a database, but not for all. It's the eye solutions for certain diseases indication. Then you know what is going on. So that's the some of the things that could be going on. Then you see what is going on. Then the next step is to deep dive to understand what is behind those algorithms and where is the data coming from. There is a big discussion right now, an eye-based app which was developed to detect skin cancer. But the data was only coming from the white people, which means you cannot detect cancer with that app for a person with a dark skin. So there are so many things that we'll be looking at, which will be exciting, like challenges, but also giving us opportunities to see where new solutions can be created. Thank you.
Thank you. Mzuri Kwao, any take on this?
Yes, I would like to add on what had been said by the previous commentators, that yes, it is very important when as we are moving on, not to just look onto the developer side or just to on the individuals who are the end users, but the general public needs to be aware of the project, regardless of the role you are playing. For regulators, they also need to understand what is AI, what it can do, what it can't do, and if it's not regulated, what might go wrong. For individuals, they also need to understand that every time when they're willingly giving up their data set, in a couple of occasions, it appears in our computers when you receive a pop-up which asks you, do you agree? Do you agree? Most of the time, we just click yes, next. Sometimes we just accept with the things which we don't understand, or we are just too busy to read, or we just ignore. But at the end, they're going to use this kind of data. So yes, we should focus on raising more knowledge to all people in the ecosystem, and everyone should play their role to make sure we develop AI which will protect the humankind. Thank you.
Thank you, panelists, for that wonderful response to the first question. And Gloria Mafole spoke about legal frameworks, looking at how our Data Protection Act is probably very broad. It's not very sector specific, but also even at continental level, this year the AU released a data policy framework, which is also very wide. But now we also know that the US has got HIPAA for so long. The EU has got GDPR, so this is very specific to health sector. This is still general. Now looking at that, how is it easy to align frameworks, especially in data sharing? Because I think at the moment, portability is not envisioned between countries, but I think in the future, when with globalization and internationalization of healthcare services, how can we ensure that people can access services globally, sharing a very good experience, but also being safe and ensuring that they get the best value from their own data and health records?
I think that's the biggest challenge. As lawyers, we are good in creating many laws. For example, in Tanzania, we have the Cybercrime Act. It's also part of the technology and whatever. We have also the Criminal Act, also saying about the same. So for sure, we have so many legal frameworks that need to be aligned, that address different issues that need to ensure that we protect people. And as you said, we really need to align to the global setups and ensure that we have individuals capable of understanding. That's why I say I really like, because in our legal framework, when they put it as a big work of the commission to ensure that they build capacities of individuals and institutions and whoever is using data to be able to understand, because we are here, few of us, knowing about the artificial intelligence. How many Tanzanians? The census said we are 61 million. Think of the 61 million population we have. How many knows about the Apple scandal, for example? I would just say, mommy, I just bought you a smartwatch, isn't it? My kids will say, oh, mommy, we want a smartwatch. And they will give them. But do they know how harmful that can be? How do we build capacity? How do we ensure that every individual knows? So to me, I think that is where we really need to invest, to ensure that people have knowledge of the technology that comes, read and understand before they accept, as you said, you just accept the terms and the reference, but ensure that as we build the institutions, they are able and capable of protecting the Tanzanian populations. So we really need to invest when the law comes into practice. We really need to invest to individuals who will be supervising the implementation of the legal framework for us to benefit and be safe in the protection of the use of the technologies.
Right, this is very legal. So we're running short of time, so I'm probably going to ask two more questions, just two questions. The first one, we've spoken about capacity of individuals. We've spoken about capabilities of institutions, data protection authorities. If we have regulations in place and people are really adhering to that, for those people who are maybe from information security world, we understand that we've got zero-day attacks and exploits. So sometimes you might really have done all you can to safeguard your data, but still there are incidents where there's data loss, cyber incidents and everything, or sometimes even intentional unconsented use of personal health records. So how easy is it to balance insurance and compensation individually, but also maybe to healthcare facilities when there are unintended consequences that might come with the repercussions of the act and everything? Giving an example of how maybe in the UK, they had an incident 5 or 6 years ago, the National Health System, they had a WannaCry incident where I think their systems were attacked and intercepted. So as we are going more digital, I think this will come. So how do we really address ensuring firms, healthcare facilities, but also getting the right compensation in cases where it's been unfairly used? Mr. Rikwao, any take on that?
Yeah, thank you very much, David. I think it's totally difficult. I don't want to use the word impossible. It's totally difficult to avoid this kind of attack at 100%. We have seen developed countries with very good people, but they're still being attacked. We have seen the attacks of even on drones. When a drone flies to a certain zone, it can be hacked and brought down. So I don't think it will be like those kind of incidents can be totally removed, but at least if we are moving toward that direction, it can be a good sign. And when we reduce the number of incidents and even the number of people who will be compensated. But when you look at most of our ICT system, most of them you'll find they are very easy and open. Even an amateur can just go in and maybe steal information. So, but at least if we are starting to move toward that direction of protection, knowing what can happen when these data sets are leaked, how hackers can use these data sets, or even foreign governments, let's put it that way, know the risk, at least we can take this more serious and at least invest more on this area. Thank you.
Maybe to add for what he has said is that to me, I think also, as he said, our approach is human-based. Okay, that should be real, putting the human face. So I think the ones who are, for example, procuring the technologies have to put the human face. The ones who are really like policymakers who allow the technologies to come in or the technologies to be used, they should put the human face to ensure that we are able to protect the people. It's not just about business. It's not about just collecting data because we want to do to the business. We want to put the humanity, the dignity in whatever processes that we are really doing we want to solve the community problem. We want to ensure that they can access, as you said, the quick health services. But if they're accessing it quickly, do they have a face of it? Do we put dignity in it? Are we sure that it's a right-based technology that really communities can use, knowing that the level of the capacity of the communities are different? So for sure, to me, it's like when we start implementing these laws, when we start importing the technologies, we really need to put the human right approach and base, especially in the privacy and the protection of the information that we get from the communities. Thank you.
Thank you. I'll relate to the new European health data law, which actually emphasizes that the person should own the data. And that, of course, comes to the issue that we are discussing here, that citizens should know more about artificial intelligence and the data being collected and all those things. And now the issue of okay, your data is being collected on an app on your phone, and you think you own the data, but where is the server? Where is it being stored? And now the big companies found out that, well, the server is on iCloud and it ends up in the US. So that's why now Joe Biden, the president of the US now, has set a commission to work on how are you going to deal with the data protection and with iCloud, and it's going to be ready in June next year. And I think that's important to follow also, because the data also which is collected here with different apps, our iPhones actually, they are collecting a lot of data all the time, real data, and how it's being used and how much do we know about it. So we give that concept here, you can use, we say yes to so many different things, but we don't know exactly what it means and how much is going to be used and how much is going to be shared. So there is a lot of capacity building that is needed at all levels, you know, at macro level with individuals, with professionals, and the procurement is complicated because the procurement officers need to understand what they are buying in. And I think that's why it is, because go-to-market is very important. So before companies get paid, those things should be clear. And also companies knowing what is demanded before they can sell. It's actually a very exciting time. I'm looking at Gloria, now law is changing. We are going to be having lawyers because, you know, individuals would be complaining, you know, my robot, which I had, which is supposed to serve me breakfast every day, it turned out to be, you know, abusive. So who is responsible now? So now we are pushed into the multidisciplinary working, which I like. We have to work together from different disciplinaries. And I think lawyers now, you are going to play an important role when it comes to laws, regulations, and policies, and how those can be implemented. Thank you.
Thank you. So I think we've seen quite an array of responses and issues, looking at rights and obligations. And we've spoken about awareness, we've spoken about capabilities, we've even touched about procurement, which was one of my questions. We are looking at how, you know, we procure infrastructure, we develop systems, but how often do we leverage things like privacy by design or rights-based approach in ensuring that the systems can fully support people and processes that we envision to have. Now, the last question is very simple, and it's around the issue of consent. So when we maybe feature consent in paper-based process that we do have, it's very easy. People can just sign and access services or let their data be used and everything. So how is it a challenge, I believe, at the moment, but also as a prospect from a technological perspective, but also from a welfare perspective, from a legal perspective too, in really building awareness to citizens, in really having supportive mechanisms and systems in places to ensure that consent, the right to consent, is exercised in people who are accessing services, in people who want to use personal health records to really look at further delivering services or aggregating data and all that. How can we have that visibility? How can we have that transparency? But also, how can we have that capacity in our societies as well to consenting the use of data? Zoripao, you're first to go.
Yeah, I think with maybe public lectures or outreach, and also when we are doing data collection, whether it be maybe in a bank when someone goes to open a new account, giving up the information, they should have that kind of concern that this data might be used for this and that and that. They should know the possibilities when how that data set is going to be used, because most of the time it happens when maybe a company have collected tons of data, and during maybe in the future they realize something that they can use with that data, and it is totally difficult to go back to the individuals who contributed to that data set to ask for their concern. It happens even in hospitals when maybe the hospital have been collecting data from the patient, their names, symptoms, diagnosis outcome, and later on maybe they find out they can use that data set to predict how much drugs will be needed for that particular hospital. And those individuals, maybe they are no longer reachable. So maybe we should try to think around on every tool that we are using for data collection to make sure that we include all possible outcome of that data set and include that as a consent to the individuals when they're coming. But on the other hand, if we don't provide enough information to these individuals, they might refuse their data set to be used. So we'll be in a difficult situation to do data analysis, to find other use of information for decision making, for policy development. So I think it's a both sides sorts. We need to first include everything possible that how the data can be used, also provide enough education and information to the individuals when you're extracting data from them. Back to you, David.
I think in the issue of the consent is something that we really have to work around it, because sometimes also, do you consent to something that you really understand? As you said, there is a long explanation, long in English. Others don't even know English. They just say, yes, I agree, I agree, I agree. Also, do we provide the consent in the language that people really understand for them to consent? That is one thing. But how long is the consent? Can we set time? Okay, I agree to use my data for 1 year or 2 years. Okay, that can also be another way on how we deal with consent, that we ask, we want to use your face, okay, in our projects. For how long can we use it? Maybe I'll say 2 years. Thereafter, it means that you can't use that, and it will be illegal to use it because I allow you to use it in 2 years. Okay, so we can have a time limit in the consent when we give, but make it in a language that is known to the communities, that they can understand. And as he said, we can continue empowering about the consent. And let's empower people to say no. If you feel like I don't want, be bold enough to say no, that I don't want you to use my data in whatever. So how do we build that to ensure that we really protect the communities?
Right, so we've probably done like half of the questions I had, but I think in the matter of time, I would like to end our panel discussion here. And thank you so much, Ms. Gloria Mafole, Professor Sarah Wamala Anderson, and Dr. Deogratis Mzurikwao.
Yes.
Oh. So questions from the audience?
Thank you very much. I have a very keen interest with I had a very keen interest with Madam Gloria's presentation, and probably it's not a question, but it's something she would help us digest, knowing she has been very instrumental in creating the document. So I remember when you talked about that there would be help and a law of how to assist whoever's been violated by the data security. I have 3 observations that I would ask you to comment on. Do we have referral pathways for victims that have had the data security breach? Or did you look into it when you were composing the bill? Also, once referral pathways, meaning, do you have like levels or ways that the victims can be assisted, be it mentally, for example, for those who've had violation with their intimate information? And also, is there a way that they can be assisted mentally with like mental therapy, psychology help for those who have been affected or exploited or abused and harassed? We have had these incidences happen so many times in social media. Once your information gets out, you can never get it back. Do you have a way to assist those people as they're seeking legal help? But also, who is held accountable to pay, or who is held accountable for compensation? We know that if this data is breached, for example, someone just leaked my, yes, you want for the people online, someone has just leaked or exploited or harassed me, and you try to make them compensate for that. We know they'll be compensated in the future, but what's the measure for the compensation? Is it because the law says it's 500? You know, some laws would say 500,000, but what's the measure? If it affects my business, if it affects my brand, to what extent are they held accountable? Thank you very much. It's not more of a question, but how can you comment and how can you make us more comfortable to really understand what goes into this? Thank you.
Actually, you really have brought a lot of food for thought. And I will just give you my understanding from the legal perspective, especially, for example, how do we deal with defamation? If I've defamed you, I've done bad things about you, I've, as you said, ruined your brand. How do we compensate you as from the legal perspective? As you said, one of my biggest challenge as a human rights lawyer, as a gender activist, is how to compensate, for example, victims of gender-based violence. You know, those who have been raped, those who have been sexually abused by anyone, those who have been done a lot of other bad things. You know, dealing with their mindset is something that I think we, as a community, we have never put a mechanism. You know, we don't have psychosocial workers. In Europe, I think they have really invested on mental health. How do we take those people step by step to ensure that they heal from whatever violation that they really have gone? And that has been a very big question whenever I meet the authorities, especially the social workers. To us as a legal profession, we'll say, okay, what the law says, it says you are supposed to pay up to 100 million. The judge will sit there, look at the evidence, assess the damage from the legal perspective and say, if I have this evidence, this is us, then you have to compensate 50 million. You have to compensate 20 million. So that is the judgment is upon the judge who sits and listen. It's upon the evidence that has been brought. But the psychosocial part is supposed to go to the psychosocial department, the social welfare department, to establish mechanism to counsel, to support this, the victims who have really undergone. And as you said, with the technologies, there are so much that is happening. And I've seen people killing themselves when the information leaked out, which they didn't. Watoto wangu wadogo mpo? Si ndio? msiwe mnaweka zile picha zenu za utupu kwenye nani, si ndio? Mtu anazichukua kwenye simu, amezihaki, anazitoa, alafu kesho asubuhi unaweza kwenda shule. You see that is what she said, that there information that leaks into the space which was not supposed, and it really hurts others, and we don't have the mechanism. So I think it's between us as a community to take the steps, especially to establish the psychosocial support after ensuring that these people have been affected. As a legal sector, will ensure that you are compensated. And we always say the one who has done the activity, the act has to compensate. Okay, so if it's a company that has collected your data, it is leaked, it's supposed to compensate you the amount which the judge will say according to what they hear from the evidence. Thereafter, we don't deal much with the psychosocial support. That is the problem. And now is where we have to build the real department and psychosocial. And I'm sure that always I ask, when I see somebody has killed themselves, when I see someone has done a very bad act, to me, I'm like, we need, maybe if we could talk to that person, they have some psychosocial problems. Then we are like, why did you beat a child to this extent? How did you kill your husband or your wife? You must be somewhere in the psychosocial problem, which we have not failed to address. So I think that is a big challenge as a community, but we have not really established a major mechanism to ensure the psychosocial support for the victims who are going to be affected by data or who are going to be affected by gender-based violence at one time. Thank you.
Asante sana. I think at this moment we can get up again and stretch our legs. So we just take a 5-minute break. We are almost wrapping up. We are almost at the end. And then when we come back, we take 2 questions or feedback from some students here. We also want to give them the chance to be heard. So we will take feedback from two students in the room. But right now, just 5 minutes break. And then we come back, take the feedback, and then we wrap up. We close. And then we go for lunch. So 5 minutes break. You can just stretch your legs or just grab some water, visit the washroom. And for online participants, you can also grab a cup of coffee or some water or tea.
All right. Our dear online participants, I'm sorry, looks like I was muted, but so far I have read the first 4 resolution items. And if there is any feedback or comment, please feel free to jump in and provide so that we can amend and rectify. Is there any for the first 4? Okay, so I'll go ahead and read the 5th one. Ensure systematic, holistic, future-proofed, and collaborative approaches in digital health solutions for meaningful data exchange and use. The 6th one is universities and research institutions should work with the Ministry of Health, President's Office for Regional Administration and local governments and other health units to conduct technology assessment and implementation science research around the existing digital health solutions, data systems, and big data. Number 7, enhance a platform for collaboration among government institutions, academia, industry, and civil society to foster research, innovation, and development in the digital health space. Number 8, government is recommended to consider establishing a regulatory framework for remunerating health facilities, healthcare providers, and health solution services through health insurance schemes. This is not the end, so I welcome any further additions from the audience. Yes. Causes. Thank you, Ms. Gloria. Any other one? As part of resolutions from the discussions we've had for the past 2 days. Sorry? Yep, I don't see anything from the online people. Our virtual participants, any additional inputs to the resolutions would be highly welcome, whether by writing or by speaking. Yes. Okay. Sciences. Thank you. So we have 9 resolutions from our 2 days agenda, discussions and presentations. And this marks then the end of this particular item on resolutions. And for the next step, I would welcome one student who has been selected, but also one particular participant from the audience as well to provide feedback. So I'd like to welcome Zainab Abbas Saad to the podium.
Good afternoon once again. As the speaker said, my name is Zainab Abbas. For sure, I'm really excited on this program. I learn a lot. As the lawyer said, I also become aware of what is going on in this world. For me, I was not really aware that as a student, I also having the right, even when somebody take a picture for me, he or she should ban concerning me. Real, I'm excited at all. And also, I'm very proudful that this my age have become aware about the digitals, how harmful it is and how benefits it is for me as a student and as a girl of 19 years old. I'm really excited and I'm too thankful for those who join the student at these issues. For real, we learn a lot. And even when we get back to our schools, we try to tell our fellow students on what is going on and how we should behave as a student and how to become innovative on these digitals. And we promise you, we will make sure that the thing that we learn today, we transform it to the other student and they all become aware on what is going on. We're really appreciating you. The education that you get and awareness, we'll work on it effectively. For sure, I need to innovate something to help my country in this digital life. For sure, on the next generations, it will be more exclusively and speedful. Thank you.
Thank you, Zainab. That was very nice and very elaborative. I would like to now invite Judith Constantine.
Thank you. Dear guests from different parts of the world and some people from different parts of Tanzania, greetings. I'm so grateful for this opportunity and I feel very honored and humbled to stand in front of you to give a vote of thanks. This was my very first time attending this kind of events. I should admit the fact that it was very interesting and so touching. I managed to attend several presentations and panel discussions and some other activities, including the refreshments for 5 consecutive days. I have no regrets. Neither do I feel like it is wasted of time. No, this is a job well done. I should congratulate the organizers and those who were able to give up their time to attend this very incorporating training. I should admit the fact that I was fascinated by the advanced technology, especially the artificial intelligence, especially the machine learning and the deep learning techniques. Being a pharmacist and a researcher, I think inventing much in artificial intelligence will bring our world and our Tanzania to a certain level of good health. And I was also fascinated by Professor Sarah. I would like to take this chance to congratulate you and thank you for opening up the opportunities of collaborations and giving us that kind of a heart, like we should work hard and attain some of the things that we need. And I should state that the fact that the sky is only the limit. We still have chance, and we are still too young to say that we are not able to do anything. I'm really grateful for this opportunity, and I should thank you for listening to me.
Now, we're going to the final phase. And I would like to call upon several representatives to the high table. Haji M. Lunga. Baraka Mbwanji. Beatrice Githiri. Crepin Kazoba. Daniel John. Davis Anthony Muhagama. Dr. Maurice N. Mbunde. Editha Lotto. Agustino Amando. Adeltus Mwemezi Maximilian. Angela Peter. Baada ya Angela Peter, Stewart F. Mamuya. Frank M. Israel. Stanley Kajaja. Pasco T. Kija. Gideon Kimario. Daniel Joshua. So those are the ones who are here, and I think we still have certificates for those who, but I'd like to call on the last one, who is here, Crepin Kazoba. And Guy Abuya. Thank you. I'd like to request the High Table if you can see. And now for the last part of closing remarks, we have several representatives on the table. So in the order, I would like to invite the representative of the Vice Chancellor / DVC.
The guest of honor, Mr. Walter Risajo, representing the Director of Information and Communication Technology at the Ministry of Health in Tanzania. The members of the High Table, all protocols observed. Good afternoon. Habari za mchana. The guest of honor and the audience, I think I'm one of the happiest person in this room this afternoon, after the whole week of carrying out the activities in ensuring the digital Health Week here at Mohas is completed. Well, I'm not sure, I'm not the right person to say this is successful one. By at least by the measure of what we plan to do, by the grace of God, we are able to do what we have planned. So on behalf of the Vice Chancellor of Muhimbili University of Health and Allied Sciences, Professor Andrea Barnabas Pembe, I sincerely send his heartfelt appreciation for the support from LM International, Maladel University, the Ministry of Health here in Tanzania, President's Office, Regional Administration and Local Government, our beloved e-government authority, GIZ, Farm Access, World Diabetes Foundation, Tanzania Diabetes Association, and other partners who have, in one way or the other, have supported all the logistics since from the preparation to the conclusion of this event. We really thank you all for the support. Can we have a round of applause for them? The guest of honor, we prepared, organized this Mohas annual event in order to foster collaboration, research, innovation, and development in digital transformation. We hope that this will continue next year in order to achieve the goals that we all aim to. And this is in line with the Tanzania Digital Health Strategy of 2019-2024, which calls upon various stakeholders and partners to support implementation of strategy. And university is best placed in supporting research, innovation, and other related collaborative activities to support the implementation of strategy. So we had training on health data analytics, as you have just graced the award of the certificate. We had 33 participants who attended the 3-day training, and we got their inputs in order to improve the training. We had exhibitions, meetings, student tour, and dialogue, and you can see we have students from Jangwani. And day one, I think they were about 30. Now we are happy that today they are also here as we are closing this event. So in total, the records that we have up to yesterday evening, we had, because this is a hybrid event, we had about 300 participants. Of course, both physically and online, and we had many online. And this event was streamed on YouTube, so we expect many other people will be following up the events after even the closing. So the information or whatever was discussed in this room will be shared globally, and it's already been shared globally, and we are receiving reaction in terms of calls for support, calls for collaboration. And we think this is an opportunity that the ministry and the government could continue working with academia and other partners to ensure we achieve a meaningful transformation. So I would like to thank you, the guest of honor, for agreeing to officiate this closing ceremony, and other participants to be able to be together until the day 5 of our annual digital week. May I now request co-chair of the organizing committee, Madam Gloria, to say a few words as a concluding remarks. A round of applause for Gloria. She was in since June this year. Very good.
Dear guest of honor and members of the high table, dear distinguished participants, today I'm so happy to see this week ending, and it's the second Digital Health Week that we are having. It's a new event, but I'm sure it keeps growing something keeps growing, and next time we'll have more other university coming, more actors coming, as Felix has said, that we started very small last year, but this year we have grown up to 300, which is a huge growth. And with time, more technologies will come, and I think we'll grow more. And out of that, we are really happy also this time to inspire our secondary school girls to participate in science, to participate in technologies, to be young innovators, because also I really think we have to really think as generational equity, that we don't just deal with the youth, with the elder and forget the younger people as they are coming, and they are many according to our census. So I was really happy when I saw the students from the secondary school around the Muhimbili universities as part of the week. But also I'm so happy to the university actually, because it's also, they have given us the venue, but also they have embraced the technology and innovations, because there are some places that is not part of them. So as they teach, they know that we are going towards technology, we are going towards digitalization. So we are sure now when we get new doctors, nurses, as they come, they will embrace technology, and it will be easy, because from the start, from their schooling, it's part of their schooling, it's part of the innovations, it's part of solving the problems within the communities. And who knew that we'll have the COVID-19 pandemic, and see how it really helped, the technology helped. So let's not say, it will not come, but that there we are with COVID, there we are with it. We need to think of how are we going to school, how are we going to have to access the doctors. So let's say it's not like it's very far, it is close to us. Yeah, it is close to us, let's embrace. But as we work along the technology, as I said, as a lawyer, let's put the human face. And as an organization, to us is about dignity of the people. When we embrace technology, we put the dignity of the people in the forefront. We don't harm people, we protect them and ensure that we solve their problem in a quick way. Thank you very much.
Thank you, Co-Chair. Next, I would like to call Professor Sarah from Maladali University.
Thank you. Thank you very much, honorable guests from the Ministry of Health and others, and especially Muhimbili who has provided this platform. I think this is really important to be able to support this kind of events, and each and every participant here, and especially the young girls. Thank you, Gloria, for highlighting that. I think that's very important. Actually, it really feels so warm in my heart when I met you the other day and seeing you coming back here. And please keep up whatever you are picking up here. I understand many things sound more complicated, but I hope they will make sense. It's about, start to think in innovative ways, how you can use technology to solve problems. I would like to mostly actually invite Dr. Felix Scombs. This is the man behind everything. Please come here. I would like to ask for all of us to stand up and give a very big applause for him. We do it in the African way. This I learned from my colleague from Malawi. It's called the chief clapping. Do you know how it goes? You take one hand. That's all for Felix. Thank you very much. And I'm so grateful all the new people I got to meet. It's fascinating to see you all young people and the technologies that MOHAS are developing with young innovators is fascinating. And I'm grateful that I met many of you, and please keep up on doing on what you are doing. And the interactions that I see between the Ministry of Health, MOHAS, and the technology developers are now coming up with new strategies, national strategies. Tanzania, you are doing great. And I think we need these events to be able to see this, because you wouldn't know that this is happening. So thank you very much. And have you decided the date for the next one? I think everybody needs to know this, because this should be the place to go to. Yeah. So I hope, this can be kept in momentum so that we continue. And I'm looking forward to seeing you again in November next year. Yes. So, thank you very much, the organizing committee. I know so many people have been behind this, supporting Felix and the leadership and everyone. So thank you very much.
Thank you, Professor Sarah. Now I'd like to welcome a representative from the ICT Commission.
Okay, good afternoon, guest of honor, high table, and all participants. My name is Haji Lunga from ICT Commission. ICT Commission is a government institution which our main function is to deal with ICT all over the country. So all and everything about ICT, we are dealing with it. That's why MOHAS invited us to participate in this important event. So I have been here since day one, and I've seen a lot of discussion and the presentation talks about the improvement or promotion of ICT in medical issues. And one of our main function as a institution, as a commission, is to promote ICT in all sectors. So I came here to see the promotion of ICT in medical issues. So what can I say is to congratulate all committee who prepared this important event. And my advice is we have to proceed on these issues in order to improve ICT in our country. So after saying that, thank you very much for giving me this opportunity. Thank you.
Thank you so much. And now a representative from the e-government authority, mixing university legacy.
Good afternoon, everyone. My name is Sospita from e-government authority. Previously, it was known as e-government agency. That's why the moderator here was confusing either it is authority or an agency. But from 2019, it became an authority, and it has been mandated to coordinate and promote e-government initiatives to all public institutions. So it assists public institutions by developing standards and guidelines on how digital solutions can be well implemented in the government and throughout the country. So I'm here to congratulate the organizers of this event for this successful event. I'm sure you have learned a lot from this event, isn't it? Also, I'd like to congratulate all participants who have participated in this. Also, we welcome you next year so that we can continue getting more knowledge on digital solutions, and we welcome all ideas on how to improve digital solution in the country. E-government, in collaboration with Ministry of Health, will continue assisting and promoting the implementation of digital solutions in the country. Thank you.
Okay. And last but not least, it's Mr. Mark from PR.
Hello, everyone. My name is Mark. First, I should greet you in the greeting words of peace. In Arabic language, we say Assalamu alaikum. In Swahili, we say Amani iwe kwenu. Hebrew, they say Shalom. My name is Mark. I'm coming from the President's Office, Regional Administration Law Government. You know, in Swahili, they say Or Tamisemi. Thank you, the guest of honor, the organizers, and all other participants. PRAG is very much involved with the digital, the health sector, because the PHC, the primary healthcare, meaning from the community up to the district hospitals, they under PRAG. So you could see the Minister of Health are the policymakers, but PRAG are the implementers. So there's that collaboration between PRAG and the MOH, as we both work for the government. We both know what time it is right now. We need to go to our favorite place, the cafeteria. So I will highlight some very, very few things. The government have made huge strides towards implementing the digital health solutions, from the community to the health centers up to the national level. The thing that we need right now to do is to make sure that we have less number of duplications of efforts. Through the e-government agents, authority, they have been our regulators. Everything that we want to do regarding the digital solution, whether it is on healthy sector or any sector, then we have first to go and conform with the e-government authority if there's a certain initiative that it has started. We could still know within the community, we have mushrooms of system out there. You see, so we have, as a government, PRAG and the Minister of Health, we have this initiative to make sure that we come with one unified solution so that everyone who comes, he could use the unified solution to implement his or her interventions. So for me, what I would advise to people is that before implementing any digital solution concerning the health, then you should go and get some guidelines from the right place. Go to the Minister of Health, go to PRAG, then you be guided well what to do instead of just coming with the because you have the finance to do it, you have the resources to do it, then you do. Then I think the good thing is to go and consult the proper institution before implementing a solution. So from the community to the primary healthcare. And right now we have these initiatives between MOH and the PRAG and the national at large. We have the NECR, the National Client Registry. It will help us, identify having that unique number that could identify our clients. If you go to Muhimbili, you go to any RRH Dodoma, you go to any other health facilities, then you could identify you without, by using your client registry number. So we're going in the very good direction, even though I know we're not there yet, but the government is doing whatever it can to make sure that we reach where we want to be. Thank you very much.
Thank you. And just one last bit before I invite the guest of honor. One of the participants was unfortunately out of the room, but he is back now, I believe. So I'll just request the high table to just stand and confer one last participant the training certificate, Dr. Maurice Munde. Thank you. And now for the last and closing remarks from the guest of honor, Mr. Walton DeSanjo, karibu sana.
Representative from PORAG, my colleague and friend Mactanda, representative from ICT Commission, IGA, and of course, the representative from here, MOAS, and Professor Sarah from the Marara University. I think I'm correct, right? And also my fellow, my dear participants, and many who are those here physically and who those participate online. Good afternoon. First of all, let me join my fellow speakers and of course all of you participants to congratulate Dr. Felix and the entire team of who organized this event. This is a well done job, and we have a lot. We learned a lot, and the good thing, we have got like how many resolutions? 9. And I think these resolutions, if possible, and of course we encourage for you participants, for you organizers to share with all organizations who are participated here officially. And when we come back for the next year, I'm sure it's going to be, as Professor said, it's going to be November next year. At least we can somehow measure ourselves. Where are we? So that we can come up with a new one for the next year, after the next forum. Otherwise, as the ministry, of course, we encourage now universities to work very, very close with us, especially in the area of not only training, even research. Of course, these researches and assessments will definitely help the ministry, help the government, to get where we want to be. And of course, by the way, the main point is to, to improve the provision of healthcare in the country using digital. So we have to encourage you organizers to encourage not only these universities, if possible, even other stakeholders also. We can have many like this one, so that at least we can, we can have different solutions. We can get there, scientifically. So we encourage you guys to continue to arrange forums like this. And let me say one thing, that soon, Minister of Health and of course PORAG, we're going to launch a Center for Digital Health, of which is going to be the environment, good environment to, for these innovators, and at least to have a place where we can have a center to develop all the digital solutions that are going to be used in the health sector, so that we can, we can have standardized solutions, we can have secured solutions. And if you remember, we had a very nice presentation from Dada Pale, your co-chairman for the organizer, Gloria Mafore, regarding the security. And of course, as you all know, not only other data, even, by the way, we normally say health data, they're more secure. My my health data is supposed to be very secure. So that we need to make sure all these digital systems, whatever system that we are going to use, they're secured. Nobody can access our information, right? Because if anybody sees your health status, maybe they may use it in different ways, which may harm you in one way or other. Otherwise, I don't want to take your time because I've got the privilege to close this session. Let me now officially say that this Tanzania Digital Health and Innovation Forum is officially closed until next year. Thank you very much.
Okay, and now thank you so much, Professor Vanna. And now we are just going to do very quickly group photos. So the first two will be inside, the first one with the high table and the organizing committee. Kindly, nimbly, can we come to the front, organizing committee? And the second one inside is to all supporters from funding agencies and sponsors of the forum and the week. Without forgetting Norwegian Church Aid, kindly. GIZ. Thank you. And now the last one, we will go outside. And after that, the next agenda is food and networking. Thank you so much. And lunch is indeed ready.